welcome to the breast cancer training edition of the town hall. And today is going to be day 2 of our training. And I think yesterday was a wonderful day. We did have, by the time we're starting, we had over 70 participants, and hoping that today we have as many as possible. So the goal of this training is to try to discuss with healthcare workers back in Cameroon and provide up-to-date data on breast cancer. I think yesterday was the most important day where we laid emphasis on screening and also the treatment and management of early stages of breast cancer. Unfortunately, in Cameroon, we do discover that most of the cases of breast cancers are diagnosed actually in the metastatic stage, given that screening is not part of the policy in Cameroon. So most of the cases are diagnosed in the later stages. So I would start with those who are here to just introduce myself for those who don't know me and why I'm doing this. So I am former Munoh Kenne, and I'm one of medical doctors. I was trained in Cameroon, and I did my medicine in the Faculty of Medicine and Biomedical Sciences many years ago. I did work in Cameroon for a long period. I worked in the regional hospital in Bamenda. That was my first posting. And later on, I was director of one of the hospitals back there in Bamenda. Then I went back for specialization where I did clinical pathology and also did a master's in public health later on, and then moved to the US, did internal medicine in New York City. Then I did hematology and oncology also in New York. So that is who I am. And I treat cancer patients, over 300 different cancers. I also treat hematological malignancies and benign hematology. So in the US, hematology and oncology is a joint specialty, and which is very important to know. And also, I do really love education and teaching. So it's one of the things I do a lot for residents and for fellows. So, and I'm part of the faculty in some of the universities. So after saying all that, today we're going to talk about comprehensive guidelines for healthcare professionals in low resource settings. I'm going to give it's more of getting the fellows, the residents, the attendings who are here to understand that we have moved out of the age of getting expert opinions to evidence-based medicine. And that is what I'm preaching, evidence-based medicine. And our students who are in the different medical schools, nursing students, need to get the evidence and actually understand it and be up to date with the rest of the world. I believe strongly that by training the young generations, you're going to make a difference. And the good thing that came out of COVID is that we can do training across the world by using very low resource equipment such as Zoom and get to the rest of the world. So I would start by just some few disclosures. I work with the Presbyterian Health System, and this is purely my opinion that I'm presenting here. It has nothing to do with the hospital I work with, and I'm not being paid for these services. So oncology care or cancer care overall is a team sport. And it's important to know this. In Cameroon, we are not used to working in teams. We're not yet used to team sports. Here, it's not about lawn tennis or table tennis when you're alone, or boxing as we had yesterday. It's a team sport. It's more about football. So if this is Manchester United and something goes wrong, it's never going to be the fault of Onana. So it's a whole team sport, and we need to understand that, especially when we're dealing with early stage breast cancer. It's more of a team sport than any other specialty in medicine. Why? Because you need everyone on board in order to make decisions. And that is why tumor boards are very important. And establishing centers of excellence are important in Cameroon if we really want to manage cancer. This is one of the books I recommend anyone who is interested in cancer to read it. It's called The Emperor of All Maladies. So cancer is the prime and everyone is scared of it, but we have made great strides in the treatment of cancer. But Africa has lagged behind because a lot of this research were done in the US and in the Britain and in the European Union and also in Asia. And these medications are not readily available in Africa, especially what I will be discussing today. It's really going to show or highlight the deficiencies we have in breast cancer. That is why yesterday I did make emphasis on prevention. So today I would just do a little summary of what we had yesterday, which we discussed, screening and local management of breast cancer, for those who were not here to catch up. We did talk about prevention. This is one concept which I have not seen a lot of people do back home, where women who are high risk, who are women above the age of 35, who have lesions such as LCIS, who have risk scores using the Gales model. These are all models that are online. You can put them in. Women with high risk can be given medications for prevention. And it's important that we know that we can prevent cancer. And I proved and I showed data yesterday showing how this can be done. So for premenopausal women, the only approved drug for those who are high risk is tamoxifen. This is not the same as when you're treating DCIS. We'll talk about that. For postmenopausal women, we did talk about they have several weapons you can use. Tamoxifen is one, roloxifene, exemestane, anastrozole, letrozole. We also did talk about the most important things really back home is screening. Screening is so important that I think those who live here, one of the message they have to take across is for advocacy for screening to be done in Cameroon. At the level of the ministry, making mammograms accessible and available, and also making them free and part of the universal healthcare package, where all women above the age of 50, which is the WHO recommendations, can get mammograms every 2 years. Without forgetting that our primary doctors need to know that there are women right now who can afford this in Cameroon, and they see them every day. So for those who can afford it, please, when you see them, for malaria, for typhoid, for all the different ailments that they come to your hospital, please send them out for screening so that they can screen themselves and get the diagnosis early. We also talked about the role of making sure our patients are well staged. This is one of the big issues I found when I have been consulted, where patients came in with cancer and also had axillary lymph nodes and nobody did a staging workup. So staging workup is important before you do any surgery. Emphasis again, women do not benefit from surgery when they have metastatic disease unless you're doing it for a cosmetic reason, and you have to let them know. There are many doctors who are getting sued now in Cameroon, and we should practice evidence-based medicine. Another take-home message yesterday was that mastectomy is equivalent to breast conservative surgery plus radiation. If you're doing breast conservative surgery and you're unable to do radiation, you should think twice about doing breast conservative surgery. That is the right thing for us to do to our women, but we just lack radiation and access to radiation in Cameroon. There is just one functioning radiation machine linear accelerator in Cameroon. So this is sad, and it's in the private sector and it's not subsidized. So this is one of the things we need to discuss. So really, yesterday when we're talking about local management, we did talk about breast conservative surgery plus radiation equals to mastectomy. We did say that please do not go ahead and start doing mastectomies when you have not checked if a woman has metastatic disease, because it's useless. And we also talked about centenary lymph nodes, which is the technique that It's not very expensive, and I feel the surgeons need to take this up and make it accessible so that women do not get axillary lymph node dissections all the time. Now, we talked about the second part of our lecture yesterday was systemic treatment of primary breast cancer. These are patients without metastatic disease. We laid emphasis on diagnosing via core biopsy. So what I said was we should stop doing FNAs, that's fine needle aspirations, because they are going to be inadequate, especially for the breast, for us to be able to do the ER, PR, and R2 status. Two, you cannot differentiate DCIS from ductal carcinoma in situ with a fine needle aspiration. Most of our pathologists are not cytologists. They are histopathologists, and they do not read cytology sites very well. I have a background in that a little bit, and I can tell you. And majority of all cancers are actually ER, PR positive. Not every cancer needs chemotherapy. Invasive lobular carcinoma, if your pathologist says that, means that 99% is ER, PR positive. You may start hormonal treatment even without having that, which I know is a limiting factor in Cameroon. We also showed this graph yesterday showing that majority of our patients with breast cancer, no matter how you look at it, data from Nigeria, from Ghana shows that 70 to 80% are ER positive. So majority of them are getting treatments that they do not need. And because they do not need these treatments, they are actually causing harm to them. So here is one table that we should take home, a take-home message. For those who have HER2 positive disease, HER2 directed treatment is actually the gold standard, which is very expensive in Cameroon. Herceptin has been existing for more than 20 years now, almost 30 even. It's still super expensive. So I think this should be added to the essential drug list, which the child is trying to do. That's the Clinton Foundation. You do have those who are hormone positive, endocrine treatment is the gold standard. Now, talking about systemic treatment for triple negative breast cancer, which is just going to make about 20% of the breast cancers we have. We give chemotherapy up front, then we do surgery, then later on we adjust our treatment. Here is a chart, which I will not go over today, just to tell you that hormonal endocrine treatment is now part of the standard of care, but we do not have Keytruda or pembrolizumab available in Cameroon, and that becomes a big problem. Now, in patients who have HER2 disease, also doing neoadjuvant treatment is also the standard of care. For those who don't understand what neoadjuvant means, is giving chemotherapy or hormonal therapy prior to surgery. And you do treat them based on their stage and how intensive you're going to provide treatment. Most of them will need Herceptin and pertuzumab, but we don't have pertuzumab available. We do have Herceptin, and it's very expensive. So this becomes a big challenge. And this is why I said prevention is really better than cure, because if we're trying to treat cancers in Cameroon, we are really going to be finding ourselves between the rock and the hard place. Now, for patients who have hormone positive breast cancer, this makes 80% of all the breast cancers. Do all of them need chemotherapy? The answer is no. Please, the answer is still no. We have the Oncotype and the Mammoprint, which are not available in Cameroon, but they are online predicting score charts. Like the Predict Online, you can just use that in your phone, and the ABC Online tool, which can help you determine if this woman needs chemotherapy or not. Most of the time, they do not need chemotherapy, and hormonal treatment is enough. This is just a chart showing you about the Oncotype. I'm not going to insist on this because it's not available back home. And here, after you do surgery for these women who have local disease, you have to put them on hormonal treatment. This is a must. For premenopausal women, tamoxifen is available, and that is what you use. You can do ovarian suppression therapy, that's Lupron, or you can use any of the ovarian suppression therapies such as glyceryl in combination with an AI, which is what we call anastrozole, letrozole, and exemestane. for premenopausal. For postmenopausal, you can use anything you want. They are all good, but the aromatase inhibitors are better. These are the side effects. We should know side effects of drugs before we prescribe them. And what is important is that we do also have to know the genetic profile, which is difficult to do back home. But this is some knowledge that is good for us to know so that when the time comes and those who can afford it, you can send it actually because there are medications that can help these women. Now we're going to move over to our talk today. That was just, how do I call it, a marathon run of what we discussed yesterday. So today we're going to talk about management of metastatic disease. As I said, this is more of a lecture which I'm putting online available for health professionals. So it's very important that they know this. So that's why I'll start with questions. The good thing is that we are not making a poll. So just look at them and then we see what, if we understand these questions, we'll be able to understand the lecture. So a 49-year-old premenopausal female presents with a newly diagnosed intraductal carcinoma, and she has grade 2 disease. She is ER positive 80%, PR 1%, and she is HER2 normal. That is, she's HER2 low. Clinically has a T3N2 disease. Given bone pain, staging workup was done, and that's what we need to always do. She has a bone pain, so you have to do that. Was performed and demonstrated bone lesions that are biopsy-proven metastatic breast cancer. The big problem we have in Cameroon is actually doing biopsy in lesions that are not accessible. This is a big job for interventional radiology that needs development back home. She reports her last menstrual period was 6 months ago. In addition to treatment with biphosphonate, you recommend as first line which of the following? So this gives us a big discussion point that all women with breast cancer who have metastatic disease to the bones, we have to do bone protection. Alendronate is available in Cameroon, zoledronate is available, those are things, but you have to send them for a dental clearance. Now, what do we treat this woman with? These are the drugs I'm going to talk about today. I'll try not to traumatize those who are here because this is really the realm of medical oncology. So what do we give this woman? We're going to give her glyceryl, that's C, anastrozole, and ribociclib. Ribociclib is a CDK4/6 inhibitor. That is one of the standards of care now for women who have hormone-positive disease. So you want to give them an AI plus this. She is premenopausal. So if you are giving her anastrozole, you have to make sure you're doing ovarian suppression. You can also use Lupron. You can also take out her ovaries. Do not give anastrozole, or you can do tamoxifen and ribociclib. That's one other thing you can do. So this helps us to build us to get into the lecture. The next question, which is still just to help you guys get into what I'm discussing. I know it can be very overwhelming. 62-year-old female without family history of breast cancer, that's majority of women do not have, is seeing you for a newly diagnosed metastatic breast cancer. She was initially diagnosed with a stage 2A triple negative breast cancer 3 years ago. She underwent a mastectomy and received an anthracycline and a taxane-based chemotherapy. After noticing bone pain, she underwent imaging studies that identified bone, lung, and liver lesions. These are the kind of patients I have. A lot of these questions are coming from my patient. Biopsy was consistent with breast cancer, ER negative, PR negative, HER2 negative. Which of the following tests is indicated? This shows you how backward we could be back home, because if we want to do something in this patient, and that's why advocacy is important. COVID helped us to get a lot of PCR machines and other things. We need to do a BRCA1 and 2 testing, somatic. Reason being that we have drugs that we can give these women when they are BRCA positive, and it can also help the family. So that's what needs to be done. So it's important that we know that. We do homologous recombinant genes. There are multiple of them, but BRCA is the most common. So the next question before going into the lecture is a 38-year-old female with strong family history of breast cancer presents for treatment recommendations for newly diagnosed breast cancer. Clinically, she has a right-sided T2N3 tumor. The T stands for the tumor size. The N, for those who don't know, stands for the lymph nodes, and M is for metastasis. Imaging studies demonstrate 2 liver lesions and several bone lesions. These are the typical cases that would happen in Cameroon if you guys were doing your staging workup, because most of those women palpated those lesions. By the time they are palpating it, they are already metastasis in multiple places. And one of the things I really talk about is I find a lot of women getting mastectomies when they don't need it. Biopsy of the breast demonstrated invasive ductal carcinoma, grade 3, ER 20%, PR 5%. She had a KI 67 of 45, and she is HER2 positive. This year is complex. It's just for the oncologists who are on board to be able to read this and know that it's HER2 positive. Liver biopsy confirmed same pathology. What is the treatment? This patient actually has HER2 disease, so you need HER2-directed therapy. And in this case, you need Herceptin and pertuzumab. This highlights one of the problems we talked about yesterday. We are going to be unable to treat these patients appropriately in our setting. We do have trastuzumab. Treatment for a year is more than millions, and pertuzumab is not available. So this makes life difficult. Now let's go over and discuss the pertinent things in this lecture. So survival is improving in breast cancer overall in the rest of the world, in the US, but there's a big problem in Africa. Metastatic disease continues to be an incurable disease everywhere. Despite multiple efficient drugs that we have right now, it remains very difficult for us to address metastatic disease. By the time most of the cancers in Cameroon are diagnosed, they are mostly metastatic disease. So what is important is that we need to understand prolonged survival is the goal. Control of symptoms, that's why palliative care is something that needs development in our society, in our environment. Those championing palliative care in Cameroon is the Baptist Convention and the Catholics. Mostly the Baptists have done a lot. We need palliative care if we want to take care of patients with metastatic disease. And we also have to minimize toxicity and think about quality of care. I would lay emphasis on this. No breast cancer patient should be treated without you knowing the ER and the PR and the HER2 status. It should not happen. Once patients have metastatic disease, it's a chance for you to rebiopsy them, which we have difficulties in that, as I said, because access to tissue is everything in oncology. No tissue, no issue. So now our interventional radiology department is very underdeveloped, and we need training in that field. We need fellowships in the Faculty of Medicine, and we need those who are accredited in Cameroon to be able to train the young ones on how to get tissue, because we have a lot of diagnostic radiologists, but we do not have sub-fellowships in radiology in Cameroon. So this is time for us to move. Breast imaging reading is a fellowship, and most general radiologists would have difficulties in reading breast imaging. Even now that we are proliferating mammograms, which is the right thing to do, those who have to read it are not well qualified. These are all facts that we have to talk about so that we get training done, and if people can actually self-train themselves to do these things, is going to help. Now, the reason why emphasizing on detection and prevention is because look at survival, even in the US. For triple-negative breast cancer, 5-year survival is less than 17%. And for HER2 positive, it's about almost 25%. And for hormone positive is 47%. And please, I repeat this, no cancer patient should die without you doing the hormone status. I've seen so many cases, and this is actually the reason why I am doing this lecture. They do not need chemotherapy. 80% of those who are getting chemotherapy back home do not need it, or do not need it as first-line treatment. This is a message that should go across the brains of everyone who is treating breast cancer. Now, you cannot treat breast cancer, and I asked this question in La Cantine Tumor Board. How do you treat breast cancer without having hormone markers? Oh, docteur, c'est cher. Le malade ne peut pas acheter. How can the patients not be able to do it when they can afford a million treatment? If you're planning to give chemotherapy, which is worth millions of CFA, without doing the hormonal status, you're doing a disfavor and you need to be in jail. Reason being that you're giving this patient treatment that you're going to benefit from, while the patient is not going to benefit from this treatment. And the fact that the patient will not benefit from this treatment without you knowing the hormonal status, this patient would have benefited more. Like most of your patients are metastatic patients, would have benefited more from hormonal treatment, then that's criminal. There are some few exceptions for patients who have visceral disease, but visceral disease in breast cancer, a lot of you will want to justify that is very rare. Very rare. And the standards of care now, they are cheaper, they are available, these women need them. Now, for those who have HER2 disease, the treatment is HER2-directed therapy. For those who have triple-negative breast cancer, which makes about 20% of our breast cancer, they all need chemotherapy. That is why before engaging, you need to know this HER2 status, hormone status before you start. Treating and giving chemotherapy, I will tell you that even in the US, it's not an emergency. I do not give chemotherapy inpatient to anyone except those who have acute leukemias, those who have diffuse large B-cell lymphomas. The ICU doctors will tell you, they call us all the time, we do not do that inpatient. Rare do we do any chemotherapy inpatient because it does not improve mortality at all. It may actually make a very sick patient die early. So in breast cancer, these are the different treatments that we have up to date. Right now, most of them were discovered actually after 2018. So those who trained long ago and who have not been educating themselves, which we find it a lot in Cameroon, because there is no continuous education, who even trained in oncology will not be able to understand the right things that are going on. That's why continuous education is important. It's primordial, it's important, and the National Medical Council needs to look for a way to incorporate that into our society. How do we treat cancers? In metastatic breast cancer, we want to sequence agents. We want to individualize treatment because the symptoms are different. We want to take into account the patient's goals and what they want out of life. Identify emergencies, which are like visceral crisis where you need to give chemotherapy. There's 3 things I usually tell my patient. Do you want treatment? And I will tell them I have treatment for you, but these are the risk and the significant harms. They have to know that. Are they in the right condition to receive treatment? If a patient comes in a wheelchair, has a triple negative disease, has oxygen therapy, chemotherapy is just going to kill her. So you need to be able to understand this. Now, when we are trying to treat breast cancer, this I took from the National Comprehensive Cancer Network, which we call the NCCN guidelines. If a patient has bone disease, you want to do bone protection medication because that is part of the cancer treatment. There is denosumab, there's zoledronic acid, there's palmodronic acid. Those are all things you can do to protect their bones. If they are not having bone disease, you want to know what is their ER, PR, and HER2 status. That is how we treat them. If you don't know that data, you cannot treat them efficiently. So rather than telling them to pay a million francs CFA for chemotherapy because they have metastatic disease, do an ER/PR status and know it first. You are going to do harm by treating this patient without knowing this data. And you also want to clearly know, do they have a visceral disease? Visceral crisis means that all the internal organs are being damaged. She had livers, mets everywhere in the liver, in the kidneys, there's kidney problems, and you may want to do something that would act very fast. But there is still controversy in giving chemotherapy to these patients. You want to know their menopausal status, especially for women. Are they premenopausal, postmenopausal? Do they want children or not, which we're going to discuss under special conditions? Do you want to protect their ovaries? What kind of treatment do they take? The next thing you want to know is patients who will not benefit from treatment at all, especially those who are triple negative, and send them to palliative care, hospice. There is data showing that early referral to hospice in the appropriate patients reduce mortality. So this is something that a lot of physicians cannot get their heads across it. But the earlier you send the right patient to hospice, the better for the patient. Now, cancer treatment is a holistic treatment. What does that mean? We need everyone on board to help us. Palliative care support, which is lacking in Cameroon, training is lacking, and we can reinforce this by training palliative care nurses, nutritionists, pharmacists, physical therapists, social work. We keep increasing medical schools without training these other auxiliary staffs that are important. Radiation therapy, surgeons, and medical oncologists are also important, but the role of radiation and surgery is minimal in metastatic disease. Radiation can help you with localized symptoms like bone pain and other things. Now let's go to ER positive breast cancer. What is ER positive? ER positive are breast cancers that have greater than 1% of estrogen and progesterone, and that makes 80% of all breast cancer. What is the standard of care? If you discover my slides are meant for those who are participating, because I have a lot of requests for my slides for those who did not even join the session. They want the slides, but they do not even have the time to participate. That is, to me, that is not correct. So for those who are here, there is data. I like to present evidence-based medicine. There is data that chemotherapy is harmful to those who have ER/PR positive disease, except when they have one, visceral crisis, or when they have inflammatory breast cancer. It is harmful for metastatic breast cancer. As first line, don't do that, please. And this is a take-home message because 80% of cancer patients in Cameroon are not getting their hormonal status. So how are you treating them? And 80% of cancer patients in Cameroon are ER/PR positive, and they are not benefiting from cheap available drugs. So how are you doing it? This is really going to be, for me, at the end of this lecture, it's a call for concern. It's a call for Central Pasteur to decentralize ER/PR status doing, should be done everywhere, in every region. And I think this is one, if we want to treat breast cancer, this is one thing we need to do, and get pathologists to advocate for this. Now, the first line of treatment for more than 20 years before this was anastrozole, letrozole, exemestane, and tamoxifen. The CDK4, 5, 6 inhibitors, we don't have them available in Cameroon, despite the fact that they have been existing for long. I will show you what the standard of care now is. You can use anastrozole, letrozole, or exemestane alone, and they are equal. And what you will realize is I've had a patient here in the US who has been on anastrozole for 20 years with metastatic disease. You will have those outliers. And she had metastatic disease, she's alive, 20 years on anastrozole. I've not even started her anymore on the standard of care right now, so you guys should note this. Women with estrogen, progesterone positive breast cancer do survive longer than the other type of breast cancers that are rare. I say this because I would still repeat the story for those who were not there yesterday. I had a young girl in Cameroon, 33 years old, died of breast cancer. Nobody did the hormone levels because they said it was expensive, but the family afforded it when they contacted me. We got the results when she died 2 days before I got the results, and she was 100% ER/PR positive. She never received any kind of hormonal treatment, but she got all kind of toxic chemotherapy. We killed her, really. Those who treated her killed her. And that is why legal litigations in Cameroon are coming. We need to keep ourselves up to date. People are getting intelligent, wise when you're taxing them a lot of money for things that you do. And data is available online. And expert opinion is going to be contrary to what you say or do. There is also fulvestrant before the standard of care, which was better than anastrozole. And fulvestrant can also be available back home. For those who can afford fulvestrant, you can get fulvestrant for your patients. 80%, I will still always repeat this, of breast cancers in Cameroon are ER/PR positive. Most of them are already metastatic disease. They do not need chemotherapy. It's going to continuously be the take-home message that I'm going to be tossing around so that anyone who gives chemotherapy should be able to justify it. Here is data for fulvestrant. That was better than anastrozole. If you can get fulvestrant, that is good. But this is no longer the standard of care. I'm just providing this because these are the drugs that are available back home. Now, what is the standard of care for first-line treatment of breast cancer in the world right now? Is to give these patients a CDK4/6 inhibitor in combination with an aromatase inhibitor, anastrozole, letrozole, or exemestane. I have all the clinical trials here for those who I'm going to send my slides to, who are oncologists who need it. But for the general public, I just want to tell you that we did do studies. The CDK4 inhibitors, there are 3 of them who are triplets, like how we have 3 of the AIs. We have palbociclib, ribociclib, and abemaciclib. You can get these drugs from France for those who can afford it. And I think these drugs, one of them should be put in the essential list of medications. This should be advocacy. Why? Because once you combine these drugs with letrozole, anastrozole, and exemestane, there is improvement in overall survival. There is improvement in progression-free survival. These women live longer. And this is the standard of care. These are the different clinical trials. Each time you see palbociclib, the trials are called Paloma trials. For ribociclib is the Mona Lisa trial, and for abemaciclib is the Monarch trials. They have different names. We did them at different levels and all of that. After patients progress on this treatment, we actually place them on fulvestrant and a combination of the CDK4 inhibitors. So that is the gold standard. What do I give to my patients? And I give it, this is a technical decision that I can talk with oncologists. I usually give my patients ribociclib in combination with anastrozole or letrozole. Abemaciclib, I also do give it. I never give palbociclib just because the data for palbociclib did not show overall survival, so I'm biased towards that end. This, for those who want to be visual, this is the difference between this former standard of care, which is affordable in Cameroon, and the present standard of care. There was overall improvement in progression-free survival. This is the Mona Lisa trials. This is the Monarch trials. All of them did show survival improvement, and this is evidence-based medicine. And that's why I would have been pleased if medical students could join so they understand how we make decisions. In decision-making, your professor's thought or ideology is a 4th-level evidence. It's nothing, okay? Right now, we're practicing evidence-based medicine. If your professor is telling you something that is not evident, it should be trashed. So overall survivor, these are the different charts here for Mona Lisa. That is why I give ribociclib. And this is for different trials. So I'm just showing you the different trials and the reason why we do this. This is evidence-based medicine. In the second line, we combine them with fulvestrant, which is available. So you can get all these drugs from Europe or from the US for those who can afford it before we do advocacy in order to make them available in Cameroon. Advocacy is very important. The thing about these drugs is that they have certain side effects and the general practitioner cannot deal with them. These drugs should be taken care of by oncologists. Abemaciclib, ribociclib, and palbociclib should be taken care of by oncologists. This is a summary of the different trials and why we give them now and why they are a standard of care. And the reason they are very dangerous is because these drugs do cause pancytopenias, severe pancytopenias. They do cause anemias and they do cause thrombocytopenia. So they need to be monitored by someone who understands hematology very well. Someone who understands side effects and how to give these drugs. But women staying on them can stay on them for more than 10 years, 20 years on these drugs with metastatic disease, please. This is a call for attention. Have I called chemotherapy since I started? This is treating 80% of all breast cancers that are metastatic, you don't need chemotherapy upfront. So here are some of the side effects that you would see. When you give these drugs, you need to know cytopenias in all of them, different cytopenias. Fatigue is important to know. Nausea in most likely abemaciclib, and prolonged QTC. We don't even have EKG machines available in all our hospitals. That's one thing. I'm not a cardiologist today, but that's something I always say. EKG is the seat vital sign, should be available everywhere. And please, those who are here, who are directors of hospitals, get EKG available, make it accessible so that medical students can learn how to read it. Now, in summary, if you have a patient who has metastatic disease, who can afford it, they will need an aromatase inhibitor, anastrozole, letrozole, and exemestane in combination with the CDK4/6 inhibitors, not chemotherapy. If they cannot afford it, there is anastrozole in Cameroon, give it to them. If they are premenopausal, give them tamoxifen. And you can still give them ovarian suppression in combination with some of these medications here. So the summary is that all patients will require a CBC. Patients will also require an EKG. These are all things that are available in Cameroon. Now, there are other combinations that I'm not going to lay emphasis on. Everolimus is a drug that should be available in Cameroon. You can combine it with exemestane. This is in the third line. This is still not chemotherapy for patients who have ER/PR positive disease. Here is the clinical trial that showed that. Here, you can also use what we call a PI3 kinase inhibitor. Apalasib is not available in Cameroon. That's where the problem is. But here, these are just to show you that majority of our cancer patients, if you don't do the ER and the PR status, you're wrongly treating your patients. You're inadequately treating them, and you're causing more harm than good. So this is really one of those things I want to emphasize in conclusion for patients who are ER positive. Sequential endocrine therapy is the cornerstone of the treatment of breast cancer. But I found this the contrary in Cameroon. From my investigation, almost every patient gets chemotherapy. Chemotherapy as first line is limited to very few cases. And patients who have true visceral disease, and now this is even controversial with CDK4 inhibitors. Most patients don't need chemotherapy. When there is resistance to endocrine therapy, we have new drugs which I'm not presenting today because they are not available. And my take-home message is also that you should know the menopausal status of your women before you start treatment. Below are the different combinations that we can give these women. We only do chemotherapy when we are exhausted all hormonal therapy, and it's usually in the fifth line, sixth line, and seventh line. So we're going to now go to a more rare type of breast cancer. We have in HER2 positive breast cancer. How do we treat them? This is one of the most challenging breast cancers to treat in Cameroon. Why is it challenging? All the medications are expensive and inaccessible. In the first line for treatment of these cancers, it can be done in Cameroon. I would also present some of the clinical trials, but I will not go into detail on them. So you can do a taxane. A taxane is docetaxel or paclitaxel in combination with trastuzumab and pertuzumab. I see this is available in Cameroon, so we should be able to test women, especially if we don't have pertuzumab, we can do trastuzumab. This was called the Cleopatra trial. In the second line, you need to check if these patients have brain metastasis, because HER2 cancer goes to the brain more than any other kind of cancer. It goes to the brain. So you want to check for brain mets. If they do not have brain mets, we give them a drug called trastuzumab deruxtecan. This drug alone got a standing ovation in the ASCO of last year. What do you mean by standing ovation? When a drug gets a standing ovation, the last drug that got a standing ovation was more than 20 years ago. This drug got a standing ovation. Why? Because it changed the paradigm of breast cancer. And right now, the way we classify triple negative breast cancer has to change because some of them are HER2-low, and it's a majority of them. And this drug can work for them. But it's not available in Cameroon right now, but you can get it from France. Then in the third line, we can use a TKI called tucatinib with trastuzumab and capecitabine. In the fourth line, we can also, so these are all drugs. For those who have brain mets, you do have to give them a drug that penetrates the blood-brain barrier. So these are the different lines of treatment, and it shows you that we can even go up to fifth line. This is really the place of medical oncology because this is where we come in. And medical oncology can be very complex. So that's why the training needs to be very good at home. The big questions we have as medical oncologists is what is the efficacy of trastuzumab deruxtecan after patient, or trastuzumab extending after patients take trastuzumab deruxtecan? Is there a role of a drug called neratinib or pirotinib in these patients? What is the comparative efficacy of trastuzumab compared to tucatinib in brain mets? Those are all answers we don't have. So for those who are medical students here, what is HER2 in the first place? HER2 is a receptor that you have at the level of the cell membrane here. HER2 is found in most of the cancers. Some of the cancers, 20% of them, you have HER1, HER2, HER3, and we are able to target them. Some of them are VEGFs, and we have drugs that can help treat them. This is what we call targetable therapy. This is what we call precision medicine, if you've heard that term. And precision medicine is driving oncology. I'm not going to go into the details unless there are questions and answers for the sake of time. So here are the different trials which I spoke about that led to the data I'm giving you. And this shows what standard of care is for first line. And that is why we have standard of care. I'm not just presenting any kind of data. And the standard of care still remains docetaxel plus pertuzumab plus trastuzumab. This is going to change in the next few years because there are clinical trials that are going to beat this drug. And we do have other targets. This is the Emilia trial that tested TDM1, which showed that we use it in the second line, but the trial came and beat it. The Destiny trial with trastuzumab deruxtecan was better. So this has become second line in those who are HER2. So this is data that I put here just to help those who are here understand that everything I'm telling them is evidence-based. In the second line, we use trastuzumab deruxtecan, which is not available in the Cameroon. In the third line, we do use TDM1. So this is a very difficult cancer to treat in Cameroon. And difficult because it's going to be expensive. If you cannot get yourself to Europe or to America, it's going to be very expensive for these women. We even have drugs in the fourth line. We have drugs in the fifth line for this cancer. So it becomes very complicated for our patients to really get good treatment. So here I'm going to give you a summary of what we do really for this patient. And this is just 20% of all breast cancer. Remember that the one I spoke about, those who are hormone positive, is 80%. So the need to know the HER2 level is important because guidelines is based on that. New therapies are changing the natural cause for HER2-directed disease. But these treatments are not available and accessible back home. The first-line treatment is available but very expensive. And that is why we should not get to this stage. We should try to attack cancer early. Now I'm going to talk about the worst type of breast cancer, which makes up also about 20%. It's more common in young girls, young women. This is triple-negative breast cancer. In triple-negative breast cancer, before 2 years ago, we had very little for them. And very little meaning that the first-line treatment was a single-agent chemotherapy. By using double-agent chemotherapy, you don't get any benefit. So what is the standard of care? The summary here is that it's just a difficult cancer to treat. Very difficult to treat, and that is why you need to know and you need to test these women. And anthracycline-based chemotherapy is actually the standard of care if they have not received anthracycline and taxanes before. There is no evidence of precise sequencing in these patients. Response rates are very low. Treatment decisions should be individualized. If you're doing combination chemotherapy, you can improve progression-free survival, but you don't improve overall survival. You only increase toxicity when you double the agents. So here was back in 2018, some few things have changed. We just kept giving one chemotherapy after the other till the patient died, really. That was what we did. And what has changed since then? I'm going to show you an interesting study which we did. In patients who have triple-negative breast cancer, we need to know what their PD-L1 level is. What is PD-L1? I know that's a term that a lot of people here don't know. Is the program dead ligand. So we want to know their sensitivity to chemotherapy, to immunotherapy. So immunotherapy was added as a standard of care. This is the Impassion 130 clinical trial that led to the approval of atezolizumab, but the FDA canceled this approval. But the only one which is approved now is Keytruda, which is Pambro, which you need to give it to women who have a PD-L1 greater than 10%. So you have to test for this. So this is very important that we know that the standard of care is changing. All women with triple-negative breast cancer do need to have their hormone status known, and it's going to be negative, but they need to also know what the immunological status is, what the PD-L1 is, because 40% of them do have a high PD-L1 and will benefit from immunotherapy. But the problem too is the same problem we have in Cameroon, that immunotherapy is not accessible, is not available. Now there are other new drug conjugates that we have. TROP2, which is a drug conjugate, is called sacituzumab govitecan. It's a wonderful drug for triple-negative breast cancer. We're having amazing results, not available in Cameroon and not available in Africa, which is sad. Available in the UK, in European Union, so this becomes sad. And I told you before, this lecture just highlights how difficult it is to treat breast cancer when you have metastatic disease. Now, there are special groups. Those who have BRCA-positive breast cancer, you can actually give them olaparib and talazoparib, not also available back home. It just reinforces what I said before, that if we are planning to treat these patients when they are metastatic, we are just not going to be able to. These are clinical trials showing that they work. This is the best study that happened in breast for many years. The drug is called trastuzumab deruxtecan. It got a standing ovation in the biggest cancer conference. After 20 years, we have never had a standing ovation. The reason it got a standing ovation is that this drug works in patients who have triple-negative breast cancer, those who have HER2-low, HER2-ultra-low disease. What is HER2-low? Those who have an IHC of 1 when you do the HER staining. And this reduced mortality drastically. We have not seen this in triple-negative breast cancer for a long time, and this is leading to the investigation of more drugs in this environment, and there is something we call the bystander effect, which I can talk about. So in conclusion, when it comes to triple-negative breast cancer, it makes up 30% of breast cancer, more common in young women. It's still a very big challenge. So the earlier we diagnose patients, the more we screen, the better for us, so that we don't get to find ourselves in this situation. There are special things we need to do which are not available back home. We need to get a PD-L1, a CPS score on all these breast cancers. They are not available. It's sad. We need to do genetic testing, the BRCA testing, they are not available. We need to be able to have trastuzumab deruxtecan is not available. Sacituzumab govitecan is not available. And this makes life very difficult. This is the new algorithm that looks a bit complicated for how we treat triple-negative breast cancer. In conclusion, the first discussion we are having here, what is my take-home message? 80% of all metastatic breast cancer is progesterone and estrogen positive. They do not need chemotherapy, except in special cases. It's not the other way around that they need chemotherapy except in special cases. No, they do not need chemotherapy. If you're giving them chemotherapy, you're actually killing them. So there is better therapy. Patients are living longer in the US and in Europe and in Asia. We need to know the ER, PR, and HER2 status for all these women. We need to treat according to the subtype. Giving chemotherapy has never been an emergency. I'm a medical oncologist, and I'm going to tell you that it's not an emergency. We don't even do it inpatient except in special cases. Think about the toxicities, think about palliative care, and don't forget that breast cancer and prostate cancer metastases to the bones more than any other cancer, except for multiple myeloma, protect their bones. And we went back to our questions we discussed initially, and I think this is the end of the first phase of our lecture. The second phase will be to talk about special cases. So we'll have a few 5 minutes just for any questions, then we'll move over to the second discussion. Please, you can unmute yourself, but the take-home message from this is just to show you how fragile our healthcare system is in treating metastatic breast cancer. We are so fragile that we need to go back and deal with prevention and deal with early diagnosis and treatment, and stop trying to feel that we can actually cure or even help these patients. We are just still very primitive and rudimentary. Any questions, please? If you have any questions, you can raise your hands. Once I'm done with the second lecture, we'll have a little time just to discuss. So, without wasting more time, if there are no questions, we can move over to the second phase of our discussion. And the second phase of our discussion is going to talk about special cases. Special cases, I hold this very dearly because this is where I would need the gynecologist to be on board and the primary doctor. So, special conditions to consider when you talk about breast cancer, which do not fall in anything I just spoke about. So, here, disclaimer still, this is my opinion. I need to say this over. It's not the opinion of a Presbyterian health system that I work for. And I would start. My normal style of doing presentations is by questions. So the first question is, which of the following statements regarding breast cancer diagnosis during pregnancy is correct? Pregnancy termination will improve the women's survival. Is that true? All systemic therapy should be delayed until after delivery. Is that true? I think you guys know that's not true. Mammography and staging evaluation should be delayed until after delivery. I hope you guys know that's not true. Anthracycline-based therapies have been used in the second and third trimester with relative safety for mother and child, and that is true. You can give chemotherapy during pregnancy. Please take that. We give chemotherapy during pregnancy, okay? Anthracycline-based chemotherapies are actually safe in the second and third trimester, even taxane. So this shows you the answer and the logic behind it. Our next question is still, I put in this because I love pedagogy in such a way that we get to, these questions are going to stimulate our minds. A 32-year-old breast cancer survivor, status post-surgery and chemotherapy for T1N1 ER positive, HER2 negative, grade 2 intraductal carcinoma wants to become pregnant. You explain to her that pregnancy will increase her risk of reoccurrence. Is that true? No. Since her menses have resumed, she should have no issue with fertility. Is that true? That's not true. She should wait at least 6 years before becoming pregnant to improve that she's cancer free. That's not true. Limited data suggests that breast cancer survivors who become pregnant appear to have a similar survivor to known breast cancer patients, and that is true, please. Our next question is a 35-year-old woman with a T2N1 poorly differentiated ER/PR HER2 negative ductal carcinoma is referred to you to discuss systemic therapy options. Although she is not in a serious relationship at this time, she very much wants to have a child in the future. You explain to her that data suggests that younger age predicts a greater likelihood of recovery of the ovarian function after chemotherapy, and she will have a 90% chance of maintaining her fertility. That's wrong. This is a serious problem when you're giving chemotherapy to women. You need to make sure that they know this, that it reduces fertility. Becoming pregnant while taking adjuvant tamoxifen is safe. That is wrong. Using GnRH analogs during chemotherapy may help to reduce the risk of premature ovarian failure. That is true. Ovarian tissue cryopreservation and reimplantation is a safe and highly effective fertility option after diagnosis of breast cancer. That is wrong. This is still experimental. So the next question, to better understand what is going on, that we're going to discuss, a 55-year-old man presents to your office having had a risk-modified radical mastectomy, centenary lymph node biopsy for a T4N1 intraductal carcinoma. Breast cancer can occur in men. Grade 2, ER-positive, HER2 negative breast cancer. He would like to know if any other treatment is necessary for his breast cancer. After explaining the limitations of data, which because breast cancer in men is rare, you recommend all of the following except adjuvant systemic chemotherapy. Yes, can be given because their oncotype score is usually very high. Radiation therapy to the chest wall and draining lymph nodes. Yes, please. I know yesterday there was a lot of controversy with some questions, but please, each of us should actually refer to data and evidence-based medicine before we talk. Treatment with aromatase inhibitors such as anastrozole and letrozole for 5 years. This is no. There is little data for anastrozole and letrozole alone in breast cancer in men. Genetic counseling and testing should be done in all men who have breast cancer, all. But in Cameroon, we have a problem because we don't have access to this, so this becomes a big problem. Which of the following is not a risk factor for male breast cancer? BRCA2 mutation is a risk factor. Family history is a risk factor. Down syndrome is not a risk factor. Radiation exposure is a risk factor. Klinefelter syndrome is a risk factor. So this is going to be the last part of our lecture, which I think I added this just because it's very important that we know that there are some special situations. And I love the fact that there are some gynecologists in here. Breast cancer diagnosis during pregnancy becomes a big issue. Gynecologists face this. Those who do high-risk maternal and infancy specialty get to see this. Fertility and pregnancy after receiving treatment for breast cancer and other cancers becomes a problem. Male breast cancer is a problem. Unusual histology is also a problem. What do you do with unusual histology, which is not similar to the ones we have discussed here, and inflammatory breast cancer? And I'll talk a little bit about what is new. So breast cancer during pregnancy, there is 1 in 300,000 or 1 in 10,000 pregnancies, depending on the country. The rate has doubled over the years because obesity has increased. Women are prolonging the age which they are getting pregnant. They are no longer getting pregnant early. They have careers. They're getting pregnant in their 40s. That is coinciding also with breast cancer. So, and we are getting larger tumors, advanced stages. Most, contrary to normal belief, most breast cancer during pregnancy is more ERPR negative, about 30%. In the real population, as I told you, ERPR negative is just 20 to 15%, but in pregnancy is about 30%. They are mostly high-grade tumors. Retrospective data suggests no improvement in survival with termination of pregnancy, as I said. So do not end pregnancy and feel that you're going to help this woman treat their breast cancer. No. So there is data showing the increased prevalence in Australia, in Sweden, and even in the US. How do we diagnose breast cancer in pregnancy? If pregnancy is not enough of a big issue and imaging, this becomes very important. Most women during pregnancy get a palpation of a mass in their breast because they are young. Nobody has done a mammogram on them. And please, if a woman palpates a mass in the breast, don't neglect it. Don't say it's just because you're pregnant, your breast. Call her in the office and examine her. If it has lasted for 2 weeks, please bring her to your office and examine. The gynecologists are the gatekeepers of this. It happens. It's rare, but it happens. Mammography is safe during pregnancy. You can get the radiologist involved. Estimated fetal radiation exposure is very low, and they should do shading. You can do mammograms during pregnancy. So please, do not give any excuses. Mammograms can be done during pregnancy. That's a factual statement. So the next thing is ultrasound of the breast is a standard, which you can do ultrasound of the breast, and the nodular basement can be done and identified in 100% of cases. Just that ultrasound is a user-friendly and a user-dependent technique. So it's how much you train them. And you can do biopsies, core needle biopsies during pregnancy. You just need to tell your pathologist that this woman is pregnant because the cells do change in morphology during pregnancy. MRI is contraindicated. MRI of the breast, because you need gadolinium. Gadolinium is contraindicated during pregnancy. You can do a plain MRI, but it's not going to help you with the breast. Now, how do we stage these women? What kind of staging workup do we do? If we're suspicious that this woman has metastatic disease, usually they are large tumors and you need staging workup. You can do ultrasounds. So suspicious lesions, you can always do ultrasounds of those lesions, do a core biopsy. You can do an FNA of the lymph node. I told you never to do an FNA of the breast, but you can do an FNA of the lymph node. The reason why we don't do FNAs of the breast is that it's not going to help you differentiate a DCIS from cancer. Now, X-rays are safe. During pregnancy, you can do X-rays. Fetal exposure is very low. You can also don't do a CT scan, please. You can do abdominal ultrasound or non-contrast MRIs. That would help you to check for metastasis in other places, especially the bones. Doing a bone scan could be risky, and you have to consult a maternal-fetal medicine specialist. This is a gynecologist who is specialized in high-risk pregnancies. I don't know if we have subspecialties in Cameroon, but you can consult your gynecologist. So what are the local regional options? This is one of the things. Surgery is safe during pregnancy. Surgery during pregnancy is okay, please, guys. There are several data that I usually put my references here, but increased rate of spontaneous abortion with general anesthesia was reported in some studies, but increase in low and very low birth weight infants has also been reported in some studies. I want to be clear. Unclear if this is due to the illness itself or this is due to pregnancy, but recent data from MD Anderson showed that it is similar. Mastectomy is safe during pregnancy, no difference in fetal abnormalities. Now, when we talk about breast cancer during pregnancy, mastectomy or lumpectomy, you guys know my take already on this in Cameroon. If you're doing a lumpectomy, there was a whole debate yesterday, and I told you guys it was semantics. And it's important you know the word lumpectomy simply came from taking away a portion of the breast, not the whole breast. You can call it breast conservative surgery. You can call it quadrilectomy. You can call it lumpectomy. It's just semantics, please. Let's not get ourselves engaged in semantics rather than the data itself. That's what drains knowledge in Cameroon when people get themselves engaged in semantics, which are not important. And in all terminologies, so you can either do a mastectomy or breast conservative surgery. Axillary lymph node dissections can be done during pregnancy. It's a bit controversial to do centenary lymph nodes because they are safe, but exposing the fetus to technetium is something you should avoid. But you can also do blue dye, which has a small risk of anaphylaxis. So you see here that during pregnancy, we're going back to all the old methods. Breast irradiation is contraindicated during pregnancy. Please, everyone needs to know that we don't do radiation to the breast during pregnancy. So if you have a woman, you do a lumpectomy, you have to wait till pregnancy is over, and then you do radiation. You can give chemotherapy actually during pregnancy. Don't give hormonal treatment during pregnancy. So that's why it's important that we talk about the special cases. Chemotherapy and hormone treatment during pregnancy. No chemotherapy in the first trimester of pregnancy, full stop. After the first trimester of pregnancy, anthracyclines and taxanes are safe. You can give them. So I do give chemotherapy during the second and third trimester. You should try to avoid chemotherapy prior to delivery when the woman gets to 35 weeks. You hold chemotherapy because you don't want to cause neutropenic fevers and neutropenia that is going to end up killing this woman because she's going to become septic. Now, taxanes, these are data. This is just data backing up what I said. Taxanes are actually safe. Anthracyclines are safe during the second and third trimester of pregnancy, but please don't be tricked. For those who have HER2-directed breast cancers, please do not give them methotrexate. Our old regimen we used to call, there's an old regimen with methotrexate, don't give it to them, please. And, okay, so someone I have to unmute. Yeah, so don't give trastuzumab to women during pregnancy. It's criminal. Hormonal treatment should not be given. Also, tamoxifen, radiation should not be given. Now, for antiemetics, if they are having nausea, vomiting, you can actually give them dexamethasone, you can give them Zofran, lorazepam, you can be given. You can also give filgrastim, that's stimulating agents. You can do, all this can be done. What is the prognosis? There are several data out there. I just put this here. There are some data showing that the prognosis of women during pregnancy versus those who are not pregnant is more women die during pregnancy from breast cancer. But the most recent data coming out from MD Anderson shows that there is no difference. And I think it's because in the MD Anderson studies, they took oncologists who treated their patients, compared them with those who treated, the same oncologists who treated pregnant patients, and they realized that survival was the same. So what is the outcome of the children? They are all similar. There is similar outcome. During first trimester, if you give chemotherapy, you're going to cause malformations. Please don't do it. That's why we don't do it. It increases malformation by 17%. After the first trimester, you give the right chemotherapy, there is no increase in fetal malformation. There is no data proving that in all the voluntary registries. Here is my little high-heel summary, that a take-home message for all those who are here. Biopsy and nodal evaluation as in known pregnant women, don't consider that they are pregnant, get it done. Assemble a multidisciplinary team. Get your gynecologist, get your breast surgeons, get your medical oncologists, the pathologists, and your radiologist and your radiation oncologist together to discuss these cases. In Cameroon, we have a big problem with interdisciplinary collaboration. We need to understand that you cannot know it all. Data is changing so much that you need everyone on board. Staging, avoid a CT scan, avoid a bone scan, and avoid gadolinium. You can use X-rays, you can use ultrasounds, you can use MRIs. Delay chemotherapy until the second trimester. Do not give radiation, do not give methotrexate, do not give trastuzumab, do not give endocrine therapy, and do not give immunotherapy. Survivor is similar to non-pregnant women. Please keep that. That's a take-home message. Now let's go over to fertility, which is going to be a big problem too for the gynecologist. This whole slide was meant a lot more for gynecologists. I have treated a patient now with breast cancer. She's coming to you, she has fertility issues, she's young. She is wanting to know what happened to her during that. By giving chemotherapy, you actually do make women become menopausal early. That's the truth. And we should know that. And that is why every young woman who comes in to get treatment for breast cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, men who come in for testicular cancer, these are all cancers that occur very young, you have to talk about fertility issues with them. If you do not, it's criminal. Here is just showing you that once you give them, there's the rainbow syndrome that gynecologists talk about, early menarche and late menopause. You'd actually shrink that. And so these women actually have earlier menopause. Amenorrhea after chemotherapy. Median time of amenorrhea after chemotherapy is 6 months. Usually when you start chemotherapy, a lot of women don't have their cycles anymore. It lasts for 6 months after you stop. And 90% of women regain it in 1 year, but some regain it, but they are infertile. The ovaries multiply a lot, and chemotherapy affects all organs that multiply very fast. They affect the testes, they affect all the Leydig cells and all of that. Risk factors for premature amenorrhea is increased age, ovarian reserve, chemotherapy type. There are some chemotherapies that are they have more effect on amenorrhea than others, duration of chemotherapy, and endocrine therapy like tamoxifen given after. So these are different chemotherapies that you guys can look at. I'm not going to spend time on it because most people here are not oncologists. You can look at them and see high risk for amenorrhea and high risk for infertility. Some of these chemotherapies are very high risk. We have already done research on them and we know. Some we don't know. So how do we do with these women? What kind of treatments do we offer them? So a lot of you may want to refer them to Professor Cassia. Those who, I don't know how far his center is functioning, and there are many other places, but it's expensive. Important issues for young women. 57% concord about infertility. They think about infertility, and a lot of them were not discussed during the time they were going to have cancer treatment. They felt that they were inadequately addressed all their concerns concerning fertility. I know in the US, this becomes a big issue because we're keeping them alive and people know their rights, but you need to be able to discuss this, and insurance companies cover it. Once a patient has breast cancer, has testicular cancer, insurance covers all their fertility preservation in the US. Ovarian stimulating and embryo cryopreservation can be used. Oocyte cryopreservation is still a technique in research, but it can be done. These women can go preserve their ovaries, they can go preserve their embryos and later on use them. Ovarian tissue cryopreservation is a technique that is under research, where we take away your ovaries and then we can implant them back on you. the main thing we use is gonadotropin-releasing agonists during chemotherapy. They help us. So these are studies really showing that if you do give women letrozole with gonadotropin medications, you can actually help preserve their ovaries. And this showed you that when compared to control groups who did not take any form of chemotherapy, who were pregnant, they were almost similar. Other things that people can do, our cultures are really very difficult for us to do this. Adoption is not very common in our culture. Embryo adoption is not even something we think about. Surrogacy and donors. So here are just studies that showed that using medications such as Lupron can actually help you preserve your ovaries. So these are different meta-analyses that were done, and they do show us that by doing that, we are able to preserve fertility. So it's very important that at the end of this, how long should we wait after you have had chemotherapy to be able to get pregnant? The ideal time is 2 years, where once it's 2 years, please keep this, because 2 years is the ideal time. I know this is a big question people ask. This presentation today was meant just to make sure that we have the data to answer some of those questions. We realize that anything less than 12 months, your rate of getting malformations is higher. So waiting time, these are the different studies. 2 years is actually the ideal time after different studies have been done and meta-analysis. Now, the next question is future outcome. Is the future outcome worse for those who had chemotherapy? It is not, please. And is it worse for those who had chemotherapy and got pregnant? It's not. It's the same. These are different studies. The Danish studies, the Swedish study, and the childhood cancer survivor showed that there was no statistical significant difference. And you should be able to counsel these women that after chemotherapy, they may have some issues, vagina dryness, because you make a lot of them get into menopause, increase UTIs. Also consider vagina moisturizers. The role of topical estrogen is controversial. I do give it to my patients. Water-based or silicone-based lubricants can be used also. Other concerns are things with sexuality, dyspareunia, because a lot of them get into menopause becomes an issue. Decreased libido becomes an issue because you drive them into menopause. Fear of intimacy and body image issues. If you have cut out their breasts, they have body image issues and do not know how to address this with their partners. Post-treatment depression, bone loss due to patients who are on anastrozole, letrozole, and ivermectin. And post-treatment weight gain is also an issue. What is the take-home message for this part of the lecture? Fertility preservation and parenthood are important concerns for our young breast cancer survivors. This is what we call survivorship discussion. Risk of amenorrhea varies by age, chemotherapy, and tamoxifen use. Counseling and referral is very important. DNRH agonists are options for fertility preservation, but do not guarantee fertility. Available data shows that no increase in mortality for women who become pregnant after breast cancer. Consider waiting for 2 years after diagnosis of breast cancer to become pregnant. Post-treatment issues continue long after chemotherapy has been stopped, and we need to be able to talk about that. Let's go to the elephant in the room, male breast cancer. Can men have breast cancer? And as I said, the answer is always yes. So men can have breast cancer. And this becomes very controversial because a lot of men think they cannot, but the risk is low. Let's look at it. So most risk factors for male breast cancer, the most common risk factor for male breast cancer we don't know why, okay? But Demographic increase in age, being Black men have more breast cancer than white. Family history of breast cancer, those who have BRCA1, BRCA2, checkmate2, RB2, environmental exposure to radiation, and the high hormones, increase serum estradiol, Klinefelter syndrome, gynecomastia, liver disease, obesity, testicular abnormalities. These are all things that can increase your risk. Genetic predisposition. For women, BRCA1 is the most common genetic predisposition. For men, BRCA2. And please don't forget, this is just to add, once you are in a family and there is a lot of breast cancer, please figure out there is also BRCA2 is responsible for prostate cancer in men, pancreatic cancer, ovarian cancer in women, breast cancer in women. But don't forget about the prostate cancer in men. So for those who look for a day and maybe talk about prostate cancer, it's the second most common cancer in Cameroon and the most common in men. Offer genetic counseling to every male who has breast cancer. These are all departments that are lacking back home. Now, treatment of male breast cancer, similar to what we do in women, really no big change. What do we do? Surgery. You can either do a modified radical mastectomy, or you can actually do a lumpectomy in this patient. You can do centenary lymph node dissection, or you can do axillary lymph node, depending on the expertise of the person who is dealing with this. Very few surgeons are very versed with male breast cancer. Radiation therapy, there is limited data, but we treat them exactly like in women. Chemotherapy, limited data in men, but we give them the same chemotherapy we give in women. Anti-estrogen therapy, there is limited data, but we do use tamoxifen is the main data we have. We prefer tamoxifen over the use of aromatase inhibitors. Hormone therapy, so this is just giving you the data I just said. There is clear data for tamoxifen use. Aromatase inhibitors, I use it. Maybe I use it because I'm a specialist there. I use it and I feel it's better, but we need more data, okay? There's not enough data. This is now my personal opinion. This is not the opinion of what is there. So you can actually do an AI with gonadotropin-releasing hormone analogs, which I do a lot in the few patients that I have, and they have wonderful responses. Now, the oncotype score can also be done. You can use your risk scores, which we have online. And really, in conclusion, for men with breast cancer, genetic counseling is important. This is a take-home message. Men should know that breast cancer can occur in men. And also, treatment of male breast cancer patients is similar to that of women. Tamoxifen is the cornerstone. If you're using an AI, you should be able to use a gonadotropin-releasing hormone analog, which I do. Unusual breast cancer histologies, tubular and mucinous cancers. You guys may have had histologies and the pathology told you is tubular, is mucinous, and you start panicking. Don't panic, they have a better prognosis. 99% of them are ER/PR positive. So just treat them like ER/PR positive breast cancers. They do not need chemotherapy. Metaplastic breast cancer is the one which is like small cell lung cancer. It's very dangerous. They are all triple negative. The prognosis is bad. Phylloides tumors, they can be benign, they can be borderline, they can be malignant. Wide excision is always what you do. You don't give them any form of chemotherapy. So radiation can be done. Systemic therapy is not recommended because they are usually benign. The other case is inflammatory breast cancer. Most times in Cameroon, everyone has told me, I started chemotherapy because there was inflammatory breast cancer. Lie. Please, they can be inflammatory breast cancer. Is a clinical diagnosis. Take the picture and send it to me. You can do a punch biopsy. Once there's inflammatory breast cancer, there is no room for breast conservative surgery. You must do a staging workup. You must. And also send ER/PR status and start chemotherapy, no matter if there is complete response. Inflammatory breast cancer is not having the ulcer in the breast, no. is when the whole breast is inflamed as if there is infection, mastitis. So for inflammatory breast cancer, it makes up about 1 to 6% of all breast cancer. More often, it is ER, PR negative and HER2 positive. It used to be one of the most aggressive cancers. You usually need to incorporate HER2-directed treatment in their therapy. And usually, if chemotherapy and HER2-directed therapy started early, then these patients do very well. In the staging, they are considered T4D. So what is the take-home message here is that start with preoperative chemotherapy. Do not take them for surgery immediately. Endocrine therapy or trastuzumab and pertuzumab if they are hormonal positive or if they are HER2 positive. Mastectomy and axillary lymph node dissection should be done. No place for breast conservative surgery in these patients. Even if they have complete response, take out the whole breast. They need post-surgery radiation, even if they have an axillary lymph node dissection, please. This is evidence-based medicine. Now, the last part of our lecture is just talking about what is new in oncology. What is new is going to be 2 minutes. It's just to tell you guys that oncology is changing. We are doing something we call circulating tumor DNA. We are able to identify, even when patients have localized disease. This goes back to Hallstatt's theories, and to disprove that most localized disease is not truly localized. There is cancer cells circulating in blood already. And right now we are able to identify them using circulating tumor DNA. And what is the implication of this? The implication of this is that it helps us know that a lot of patients, it helps prognosis. A lot of patients, you may need to give them neoadjuvant therapy if they have a positive circulating tumor DNA before you do surgery, so that you clear off the circulating tumors and you are able now to help treat these patients better. There are several trials. It's going on in all cancers. We are having next generation sequencing being done in all cancers. What do we mean by next generation sequencing? If you've heard about the Human Genome Project, which sequenced all of human genome, which did not include African genome, that's the sad part. We do know that we can sequence the genome of all cancers. We do that now in the US in less than 7 days. And you are able to understand the genomics of the cancer, and you can use targetable treatment. That's what we call personalized treatment. There is no field in medicine that has personalized treatment like oncology, no field. We are light years away from most other specialties. So most cancers now can be treated with personalized medicine depending on the driver mutation that is driving these cancers. So here is just showing you several of those clinical trials and their implications and how they are changing medicine. These are the same question I asked in the beginning. And I think we have had a war-run tour. We are going to stop here and take some few questions. We'll have about 30 minutes for discussion, and please, you can always unmute yourself. I do like it that way, to be interactive. And if you have questions, please be precise with your questions. If you have contributions, also be precise. So if you have any of that, please, you can actually unmute yourself. And then, yes, Dr. Erwan Dunya. That's a surgeon, and he's in Douala. That's my classmate. You can unmute yourself, Erwan.
Good evening, Munoh. Good evening to everybody. It's a pleasure, as usual, to have this discussion that was very, very interactive and very interesting discussion. And I have some few questions. My first question is concerning mammography in pregnancy.
Yes.
Knowing that usually when you have a dense breast, mammography seems to be not very effective. And that in our setting, most of women are very young when they are pregnant. What do you think about, do you still consider a mammography as the first thing to do, or echography will be the best? What do you think, especially in our setting?
Very important question. And it goes back to the guidelines. And thank you for this question because it helps to clarify things. Women who are less than 40 years old, echography is actually the gold standard. Then you do mammography after. And so in these pregnant women, doing both is very important, especially if you're suspecting, because the woman comes to you most of the time. These are not women that you just go ahead and do mammograms or ultrasounds on them. It's because they found a lump. That's why diagnosing breast cancer during pregnancy is usually later stages. So you are right. Breast ultrasound done by the right person who is trained for it is appropriate. And follow-up mammograms are safe. Dense breast is a big issue in Black women. So, but breast MRI is not allowed in these cases because of gadolinium. So you are very right that you have to combine both modalities. And we do actually combine them even in women above 40 when you're doing a diagnostic mammogram, which is different from a screening mammogram. In this case, you're going to be doing a diagnostic mammogram anyway. You do an ultrasound alongside.
Okay. Another question is concerning the male breast cancer. After using tamoxifen, does it have any effect on fertility in men?
So male breast cancer, there is no proof of it causing infertility, but it's a field that is under research. But using aromatase inhibitors and using GnRH also kinds of make men feel like they're having menopause. If you've ever given a man Lupron to treat prostate cancer, they're going to tell you. They feel hot flushes, they feel bad, their sexual drive drops. It's a terrible drug for all of them. Okay, so yeah, it's one of those things. But after stopping the drug itself, there is no data to prove that during the time they are taking the drug, there is fertility issues. But after stopping the drug, there is no data to prove that it increases fertility because there's very little studies. Those are all areas of research.
Good, thank you. My last question is, you said something particularly. You said consider pregnancy at least 2 years after diagnosis of the breast CA. I don't know if you wanted to say after 2 years after ending the treatment, or if it's just after.
Yeah,
diagnosis.
two
Knowing
years
that in our milieu, here, normally, I mean, like the gold standard is that when you see a suspect mass, they used to tell us, the bosses used to tell us that we have within 2 weeks to have all the information and take the next course. But here, sometimes it can take you 6 months to have all the information. So will you still consider 2 years after, or will you consider 2 years after starting a treatment, or 2 years after finishing the biggest treatment, at least? What do you think?
2 years after finishing the treatment, Dr. Dunia. That's a very important question. Your questions are very, very good questions to help clarify things. Here, as you said, you trained in Ghana. Things are different in Anglo-Saxon countries. People prioritize where health needs to be prioritized. And you are right that you need 2 weeks to get all the data that you have. But I'll always say cancer is not an emergency. Don't run too much. You need to have data to make the right decisions. In Cameroon, if the data is going to take you 6 months, then the woman is going to progress, obviously. So you want to have everything within the framework of a month and make the appropriate decisions. So your interventions were very spot on and helped clarify certain things. So do you have more questions? I'm sure you should have more.
No, just what I can tell you now, I don't know about the experience of the other guys on the field here in Cameroon, but it takes at least 2 months to have the ERPR status. That is, if you have been able to get it. Because I've discussed with the guys at the Centre Pasteur, they will take you 2 to 3 weeks to get the histology, another 2 to 3 weeks to have the ERPR status. So usually when they say like that, we used to know that it's something like 2 months. And then after that, you can imagine that the family have to gather the money for X or Y or Z. So usually it can take some time. That's why I say usually here, I'll hardly have just the ERPR status with less than 2 months. And sometimes by the time they are doing it, they can't do some maybe the extension, the X-rays and everything, because they say they don't have money. So it can be quite difficult to get everything. It has taken me sometimes 5 months for the patient to have all the information and sit down and say, okay, this is how it will go. So is there anything that any advice that you can tell us what a course of action?
Yes, Erwan, this has been, we have had discussions, both of us. You're one person who calls me every time we have cases. This is a very important thing, learning to prioritize. Once you get a woman and you do a biopsy, to me, the priority should be staging workup. If this is a woman who has at least a T3 disease, the mass is that big, and has axillary lymph nodes that are palpable, do a staging workup. It is 50,000 francs in Cameroon to get a CT scan of the chest. Do me a CT chest, abdomen, and pelvis if it's possible. You would even see bone lesions there. The radiologists, a lot of them are good. We have good diagnostic radiologists that will tell you. If there are bone lesions, they will tell you. You will not need to do a bone MRI or a CT MRI most of the time. But just by doing that staging workup, you know if you're dealing with an emergency situation where you need to do surgery or no surgery. As I told you, surgery is useless in patients who have metastatic disease, full stop. The next most important thing in my priority is making sure they have that 50,000 to send or 100,000 to send for ER, PR, and HER2 status. You cannot make, based on all my 4 lectures, I've made it very clear, you will not treat these women adequately without knowing that information. And that is going to be my point of advocacy to the minister. You cannot do that. You will not be able. IAC should not be complex. You studied in Ghana, you know that. Every regional hospital in Ghana can do an IAC. Why should it be that complex in Cameroon? The next step, if this woman has metastatic disease, this was a discussion I had with you. If you know that there is no visceral crisis and you know that 80% of breast cancers are ER positive, what treatment will you opt for? Will you opt to give her chemotherapy that costs 1 million francs, or will you try endocrine therapy when waiting for the results to come back? Erwan, what will you do?
Of course, I'll go for endocrine therapy.
Thank you. And this is where the debate has always been in Cameroon. There is no logic when people want to propose treatments. That's why epidemiology, I'm a public health specialist. Epidemiology is important if you're in a resource-poor country. And I have a woman, I've just proven to you with data that women with metastatic breast cancer who have estrogen and progesterone positive breast cancer do not need chemotherapy. This is a fact, unless in special circumstances. This is factual. Chemotherapy is going to kill them faster. It's not going to be durable. They need hormonal treatment. So the question I always ask people, you're not doing this, is not guideline directed. It's important. If your data comes back and tells you that it's a lobular carcinoma, you give hormonal therapy because 99% of them are hormone positive. If it's doctor, 80% of them are hormone positive. It's miscellaneous, 90% of them are hormone positive. So you know that once you have that epidemiological knowledge, and I think GPs can save most cancer patients in Cameroon, more than some oncologists who do not want to keep themselves up to date. GPs can save more patients by actually introducing the hormonal treatment. That is why I am maybe controversial, but I'm of the opinion the good thing with Zoom and moving forward is that knowledge is not meant to be. When we were in medical school, you know that. Nobody gave us this kind of lecture during our medical training, Dr. Erwan, you know that. Nobody. Nobody even gave us a focus point on how to identify things and move forward. The logic behind certain things. I was speaking to a friend yesterday and we just spoke about myself and the friend. She's an infectious disease. Cameroon has an infectious disease burden, but Cameroon has never trained an infectious disease doctor. They feel that all GPs are infectious disease doctors. That's why we have problems with antibiotics, antimicrobial management. We have problems with infectious disease. I trained as a clinical pathologist. A lot of my colleagues feel that they are infectious disease. They are not. And this has become a big problem. So we need to go back to our universities and be critical. and decide what kind of specialists we're going to train. The other day in a forum, I made a statement. How do we train 20 cardiologists in a country where we're training 10 internists? Internal medicine is the guardian of medicine in any country. They are supposed to be those who understand medicine, the savoir-faire in medicine. If you're training 20 cardiologists directly as cardiologists, they don't even get internal medicine training, and you're training 10 internists, you're doing something wrong. As a country, you're mimicking France in a very wrong way. And Cameroon has been doing that for a very long time, and that is why we still have all these problems. And that is why we have problems in preventive medicine as a whole, because there is chronic lack of knowledge. In some specialties, some of them are excellent. Pediatry, excellent specialty in Cameroon. GYN, multiple excellent ones, but there are some that really have a problem. It's until I did come here, I understood that the worst training I had was in internal medicine. That was the worst part of my training in medical school. And it's a problem we need to talk about. You cannot really encourage preventive medicine in a country where you're not training good internists. You cannot. So Erwan, do you have any other question or someone else?
No, thank you very much. Very, very interesting. Thank you for the answers. Thank you very much.
Please, if you have contributions or questions, just be precise, and you can also lift your hand. Yes, please. Betelia, you can unmute yourself.
Okay, thank you, Dr. Munoh. I have a quick question on the male breast cancer. Is there any screening procedure for male breast cancer?
We don't screen for male breast cancer. There is no evidence. So screening in public health is based on the number needed to treat, okay? When you do public health, we've just told you breast cancer is very rare, very, very rare. But once here in the US, I screen patients who are BRCA positive, patients who have checkmate 2, those who have BRCA1, BRCA2 genes, those who have family history of breast cancer. So that's why you should question your patients. They should know their family history. Those are the patients that need screening. Screening mammograms like women. Every 2 years, those men need it. And because you are going to screen them for other cancers. So patients who have family history of breast cancer usually have family history of prostate cancer. Those who are BRCA2 positive, they have family history of pancreatic cancer. And the women may have family history of ovarian and uterine cancer too. So you want to check. Those who have Lee-Fraumeni syndromes, they do have cancers of the kidneys, cancers of the gastric intestinal tracts. They have cancers everywhere. They have P53 mutations. So you do not screen generally for breast cancer, for male breast cancer, because the number needed to treat is going to be too high. You're just going to be wasting resources, okay? So it's just about resources. You may want to screen, but you will screen 1 million people and not see even one.
Okay, thank you.
Yeah. So please, if there are any questions, you can unmute or contributions. I would love to hear from the gynecologists what their experience have been with patients who have cancer during pregnancy or breast cancer during pregnancy and how this is taken care of. Dr. Wiban, anything, any experience with this? Dr. Wiban.
Yeah, hello, Dr. Munoh. Yeah,
hello.
Thank you for bringing me online. Thank you very much for your brilliant presentation. My first contribution was going to be on this issue of fertility preservation. I want to say that it is possible to do fertility preservation in Cameroon. You mentioned a couple of them, like ovarian resection and all the like being experimental. I think it is proven that it's working well. Huh? It is possible to do it, and it has good results. And that we have our grand frère, Dr. Sanjon in Douala, who has everything that is ready. Certainly, Professor Cassia in Kasser also have enough equipment. There are other private initiatives that are being taken in Cameroon to be able to handle that issue. Yes, cancer in pregnancy is really a very challenging problem, and I should say that the opinions have often been very mixed. Sometimes we have made that mistake of thinking that it's better to wait and have the baby out before attempting. But your lecture this evening has enlightened so many things, especially on chemotherapy, whereby you are so emphatic that on second and third trimester, chemotherapy has no problem.
Yeah.
Unlike what we could have been thinking that even during second and third trimester, the baby's organs are growing and may be affected by chemotherapy, and your evidence base is showing the contrary. So thank you for that. Like you said it all, I think we have a great problem of organization in Cameroon. We have the human resource package is there, and organization is the major issue. When we get organized to get tumor boards, to get teams that are ready and willing to work together, without some claiming to have monopoly of knowledge, which they don't really have, and really opening up. Because one thing is, if we are where we are today, it is because generally those who were properly trained have not been practicing it properly. Because when you practice properly, there is the contamination effect, whereby the mass of circulating knowledge improves instinctively the other younger colleagues, and they see that this is what this senior does, and they copy it. So thank you very much. We are starting something. Continue, keep up, and it helps all of us. I think that is the little I can say for now. Thank you, Dr. Munoh, and the rest of the team.
Yeah, thank you very much, Grandfriend. Thank you. And thanks for the information too, that at least it enlightens us all that I knew before leaving Cameroon that there was a lot of innovation going on around fertility medicine in Cameroon. So this is a great information for us to refer patients to Dr. Sanjon when we are thinking about this, and to Professor Cassia, and also get them think about it for those who can afford it, so that after chemotherapy, they can be able to have kids. And women put a lot of their sense of well-being in the act of being able to have kids. It's very important for women. So I would also, if there are no more questions, ask on Professor Joshua Tambe if he has something to say, to add, to contribute, especially in radiology. He's my classmate and a very brilliant person I respect a lot.
For the opportunity. As usual, I had to sit back and learn a lot from the presentation. Kept on inviting some of our students. I hope some few of them actually showed up. But it's a very, very great presentation that you just enlightened us with. Well, for the radiological aspects, I understand that much of your work wasn't actually geared towards that. Well, for screening, of course, the role of mammography and the ultrasound. But then we also have a metastatic workup, which typically what we do, we're going to use a CT of the chest, abdomen, and pelvis, and then MRI. Unfortunately, we do not have nuclear medicine studies. All of our equipment, we had bone scintigraphy, but that equipment for some years now hasn't been functional. And we don't also do positron emission tomography. All of these are very, very important for metastatic disease workup. So for now, we rely just on the CT scan and on MRI. But nevertheless, once the indications are well spelled out, we can still do a lot with these imaging modalities. Much of the problems we keep on having is we receive request forms and we actually don't know what the requesting physician wants. Often you are not told this patient has a cancer and is on treatment, and maybe it's mid-cycle chemo or radiation therapy. You just have a form like that. So, well, if you don't have if you don't give us all the information, at times it becomes difficult to be very, very precise also in the reading.
Yeah.
I think the quality of mammograms too is increasing because it's quite a challenging exam, a challenging study. It takes a lot of time, and it takes additional training after a usual residency to be able to do mammograms correctly. And a couple of colleagues are into it. Myself, I'm into it. And it's very, very interesting. But then we still have a problem of people not being able to distinguish when a mammogram is being requested as a screening mammogram or as a diagnostic mammogram. So many of our colleagues do not understand that. And another problem I always have is the fact that a lot of our GPs are too autonomous in the way they use some of these studies. You know, there's no specialist supervision or vetting of so many of the studies. So at one point, a lot of studies are requested for our patients. And believe me, some of these studies at times are quite irrelevant. Then I don't know if you talked about non-mass lesions, non-mass lesions for the breast. Well, you addressed the core biopsy yesterday. I had a word, but well, yesterday there were a lot of reactions, so I couldn't say much. For the core biopsy, at least the discussion had moved from fine needle aspiration to core biopsy a long time now. And much of the debate in recent years has been on the kind of core biopsy, whether you're going to do a 14G, 16G, 18G. And many studies have proven that a 14G core biopsy is the best if you intend to have sufficient tissue. But for non-mass lesions, what do? I'd like to hear your thoughts, because stereotactic biopsy is actually what is being practiced. But I don't know any center in Cameroon that does stereotactic biopsy. Well, there's a project for stereotactic biopsy with Claire. Unfortunately, Sydney is not around today. But that is it. So if you have a focus on microcalcifications and then there is no palpable mass lesion, it kind of poses a problem if you have to go and do a lumpectomy or whatever Professor Wileji may want to call it, and you actually miss the specific focus where you have the grouped microcalcifications, which are actually going to herald maybe a lobular carcinoma inside to a ductal carcinoma inside to. But nevertheless, we are making strides, and I think doing a multidisciplinary meeting like what we are just from having is usually the best. I'm not a medical oncologist, but as I said, I do oncologic imaging. So I learn a lot from the medical oncologist. I learn a lot from the other specialists who are here. So it's when we come together and talk together that we build the body of knowledge that we all need to have to be able to treat that patient. I learn a lot from the surgeon. I learn a lot from the oncologist. And each time we come, we learn a lot from each other. It's so that each specialty is improved by the other. And when we come together, it produces desired effects for our patients. So once more, I can only join my voices with the others and thank Dr. Munoh, who is always present and straight to the point. Believe me, much of the synthetic information he has given, you will spend hours and hours and hours trying to filter that information from many of the textbooks and articles around. Dr. Munoh has just given us a critical summary. In fact, what you need to know after you must have forgotten every other thing. That's what Dr. Munoh has done. And for that, I can only say thank you very, very much, Munoh.
Yeah, thank you, Professor Tambe. And it's important. You have raised a lot of things that are very important that we didn't talk about. We didn't talk about the imaging aspects, which we think we need a lot of knowledge. And as you said, things are getting better. We need investment also in PET scans. We need investment in scintigraphies, biopsy techniques. Radiologists here in the US are the gold standard for any kind of biopsy. Stereotactic guided biopsy, Joshua, is what you really need for those cases. And we need to start getting training, and the trainings have to be given to radiologists because they understand imaging better than all of us, and they understand the implication of whatever image they are going to biopsy. It's not the surgeon who is going to biopsy lesions that are not available, that are not even there. So all those micro-calcification, as I said, DCIS is actually a radiological diagnosis, which is confirmed by pathology, which is a stereotactic biopsy. Now, for those who come in with inflammatory breast cancer, inflammatory lesions, you can do a punch biopsy. Usually that's what you do, like what you do for dermatology, but any other thing which you cannot feel that is there, going and doing a lumpectomy is really not the right thing to do. And in these situations here, you need stereotactic, and I'm happy Clear Radiology is actually investing in this. And there is also MedRad, which is investing in trying to help our radiologists back home get to practice more of, because here in the US, I don't know exactly in Europe, breast radiology is a subspecialty after general radiology. For 5 years, you do breast 2 years, just breast. So breast imaging and biopsy is actually done by a subspecialist. And that I know you for keeping yourself up to date more than anyone else. And you do also, interventional radiology is a subspecialty for 2 to 3 years. And really, they have taken surgeons out of the job in terms of getting us tissue. No tissue, no issue. Meaning that even the screening part of medicine is all in the realm of internal medicine. I do not screen patients as an oncologist. I see cancer patients who have been diagnosed. So the oncologist job is so huge that I am not even involved in screening. If you're doing screening for colon cancer, please go meet the gastroenterologist. If you're doing screening for lung cancer, go meet the pulmonologist. Dr. Brunhilde is going to tell you. They are the ones who are the gurus and identifying lesions and what those lesions may mean. My job comes in when you have a diagnosis of cancer. Because I'm dealing with 300 cancers, I cannot be involved in screening them. And that is why the gatekeeper of a healthcare system needs to be a good, well-trained GP. If we are still training our GPs to take care of infectious diseases, then we need a good, well-trained internal medicine specialty that is going to be the guardian of our healthcare system, especially when it comes to complex diseases. So thank you very much for all those contributions. And we would look forward to actually contributing with MedRad, which is an organization in Africa that Cameroonians have been in charge. I think Sydney is now the president of MedRad Africa. He used to be Dr. Foyon Kennedy, who we schooled together. Also, he's a neuroradiologist trained in Yale and John Hopkins, but he used to be president and did a lot with Bingo to try to reinforce that they have a lot of financial availability things that they can help train radiologists more. So I think that's some person we should liaise with. And Joshua, I think you know those two people. I may put you in contact. You know them very well, so you can be a pivotal point, at least, for us to get further training to our radiologists back home.
Yeah, I know them very well. I've met them, so you don't have to introduce them again.
I don't have to introduce you to any of them. You know them very well. Yeah, so any further contributions, please? I have Dr. Innocent Bibi. You want to say something? Any questions, Innocent? If not, I just want to get...
Hello, do you hear me?
Yes, we hear you, Professor Waleje.
Yes, thank you so much for your great talk. I missed most of your second session, but I just want to reiterate a few things. I just hope you will not mind me just trying to get things right a bit more, especially with regard to the diagnosis of breast cancer and the assessment. I just want you to know that the core biopsies have got a sensitivity rate or specificity rate which is not 100%, because you may miss the appropriate sampling of the actual tissue that you need. And that is why they still evoke for excision biopsy. You mentioned the other day that excision biopsy should not be done. First of all, most of the doctors here don't have the true core biopsy equipment. So excision biopsy is still very important. You have 100% sensitivity and 100% specificity. Okay, with true cut biopsy, you must be an expert. You might miss the representative sample from it. So I don't think you could put excision biopsy away from it, but it should be done properly. It should follow the skin lines. It should be in the notion that you have to do breast conserving surgery later, following the results that you get from it. So, and of course, you have to excise everything together with the scar. So I don't think you should put away excision biopsy as a very important means of diagnosing breast cancer. Secondly, I just wanted to say, with regard to most of my points are with regard to surgery. With regard to the assessment of breast cancer, we should know that there's a triple assessment, which is very important, and they complement each other. And the more you get the clinical assessment, your biopsy, and your imaging right, it increases the diagnostic ability of you actually having confirming that you really have breast cancer. So it's a triple assessment. Together, you get a better diagnostic yield. Okay, so you cannot do it with just, and then thirdly, the confirmatory, what confirms that you have breast cancer is actually the histology. That is what, so the biopsy is very important. The mammogram doesn't really confirm. It simply tells you if there is some sort of cancer, if it's bilaterally affected, breast, if you have multinuclearity, multi-cancer, if you have DCIS. So this, it's not definitive. You must have to do a biopsy to actually be sure that the patient has breast cancer. And mammogram is useful only for the patients who are above about 50. The younger patients have got dense breasts, and mammograms are not useful for young women. Ultrasound is the best diagnostic imaging for younger women. All right. And then thirdly, there's a lot of bias with mammogram. Okay. There's a lot of problems with actually using mammogram as a screening test. You know, there's a lead time bias, there's a length bias, and there's a selection bias. Now, why am I telling you this? Most of the cancers which are aggressive, screening does not do anything in picking them up early, because whether you catch it up early or not, it still must have spread rapidly before you actually get it right. So screening is only good for the slow-growing tumors. So there is limitations with mammogram. And that's why I still insist that it's important, yes, but it has its limitations. And that is why I still believe that women should learn how to examine their breast to know what is normal for them. And if there's any abnormality, they should pick it up early. Most of the diagnosis of breast cancer is done by the women themselves. But your talk is excellent. You've really oriented us on what we should do. And I like what you said about the receptors test, which is very important. But now I thought about it. I said, but as you rightly agree, since most of the patients are estrogen positive or progesterone positive, in my practice, I just put my patients on tamoxifen whilst waiting for the result of the immunohistochemistry. I still think it's safe to put these patients on tamoxifen whilst waiting for the result, because most of them are actually estrogen positive and not. Now, the patients who are, I agree with you, the patients who are stage 2, stage 3, stage 4 disease, no point in doing any operative surgery. The cure actually will only come from you attacking the metastasis. So I totally agree with you that neoadjuvant chemotherapy for the advanced tumors, or the very, very advanced, or the local advanced tumors, or the advanced tumors, is what is required. So that's just what I wanted to add to all what you have said. And I'm glad that you are now using the word lumpectomy properly. Lumpectomy is actually an excision biopsy. It's not a definitive breast-conserving surgical excision or chorectomy. Okay, so I agree with you totally. And of course, if we get into the axilla surgically, we should not get into it radiotherapeutically. So we should decide if we're going to use it as a means of clearance, because it is diagnostic. It reduces the disease. It gives you the disease recurrence locally. So it treats the disease locally, which is also useful. The disease-free interval reduces if you clear the axilla. If it's mobile, and it's not,
thank you, Dr. Waleji. Let me just respond to some few things. And I thank you for your contribution. But the few things are more of, I just want the students to get evidence. One, if you do axillary surgery, you can still do radiation. depending on the number of lymph nodes that were positive, please. That is evidence-based medicine. 2.
Yeah, no, yeah,
No,
what happens is that,
sir,
let me just
please,
say,
that is based on evidence. So there is
I just want
data, there is data that is available, and it's not something that I'm creating. So there is data that is available based on that. And that is important for students to know that this is evidence-based medicine.
Okay,
2,
I want to
when it comes to screening.
Please, can Professor Weleji mute himself and listen? Thank you so much.
Yeah, when it comes to screening, there is data that shows that when women are less than 40 years, that is really it, an ultrasound is better than a mammogram, as you said, but not 50. So anyone above 40 years and above, mammogram screening is actually the screening modality of choice. This is evidence-based medicine. So 50 is an ideal age for screening as per WHO standards. And it's important that we know that. For WHO, they recommend screening from the age of 50 right to the age of 75 every 2 years. Now, when it comes to other associations that are found, they all have different modalities in different countries based on different things. The task force in the US recommends 50 years. The American Oncology Association recommends 40 years and 45 years and screening yearly. So these are all things that are important for us to know. When it comes to dense breast and younger women, ultrasounds are better, especially women less than 30. Between the age of 35 and 40, the guidelines are not very clear. Now, when it comes to the diagnosis of breast cancer, as we said, cancer's diagnosis is a diagnosis of pathology. No tissue, as I said before, no issue. You need a pathological diagnosis to diagnose cancer, and I've made that very clear. Without a pathology, you cannot diagnose cancer, except in rare cases. Some of those rare cases, we are actually taking them off. The diagnosis of hepatocellular carcinoma can be made radiologically, but because of advancement in pathology and treatment, we still need tissue right now. So we are getting to the point where we need tissue for hepatocellular carcinoma. Also, the diagnosis of renal cell carcinoma can be made radiologically and surgery can be done. But because of advancement in treatment, you don't actually go into biopsy the kidney. If it's localized disease, you take it out. So those are the exceptions. Even testicular cancer, you don't biopsy the testes. So I'm saying this because I'm coming from an internal medicine and an oncology standpoint, so I do understand the whole concept. So you do not. And then the controversies, as I said, between the word lumpectomy is semantics. Let's stop keeping ourselves on semantics. You can Google that. Lumpectomy is a term that was used for many years. You could want to call it a lumpectomy, a quadrilectomy. These are all semantics, and we are not here to really quarrel about semantics. We're here to make sure that medical students get the right thing. And I'm encouraging medical students, please make sure you learn evidence-based medicine. Medicine is not about people's opinions. It has never been. It's about evidence. And once we get to that in Cameroon, we are going to progress. So it's very important that we take that as a home take message. So I'm going to call on Dr. Charles Elom. Can unmute yourself, please.
Hello, can you hear me?
We can hear you. We can hear you, please.
Thank you very much, Dr. Munoh. Thank you very much for organizing this forum. My name is Dr. Charles Effiong. I'm a family physician based UK and with a specialty in diabetes. And I think such a forum actually that brings about evidence-based medicine is something that is worthy. But I want to come from a point I worked in Cameroon for some years. What is happening at the moment in terms of if a general practitioner sees a patient that he or she is suspecting that patient may have a breast cancer, what is happening at this moment? So that let me just get a picture of what happens. Is there a referral system? Is there some sort of an initial investigative system, or what is happening? I've not practiced in that country for a long time, but when I went there I was there in October, and I was talking with some of the clinicians there, and I was very impressed with the guidelines that are being sent around. So I think in a way, there are some positive measures that are being taken along this line. My humble take on this is that after all these discussions, can we just have some sort of a simple guidelines that if you see a patient that you're suspecting breast cancer, these are the options, these are the options. Is there something like that operating? And I think the role of the family physician is very important in terms of prevention, in terms of creating awareness, in terms of educating the public. And we have a huge role in that. Yes. So if anybody who is working back home can just give me an idea, if let's say I go there and I have somebody who has, that I'm suspecting that may have breast cancer, what am I supposed to do? Thank you very much.
Thank you. I would call on those who are back home. I studied back home and I specialized back home before moving to the US. So I have a little bit of an idea, but I would like this question to be answered by those back home. Those who do see, I don't see the GPs here, but I do see some gynecologists and I see some general surgeons. So I'm going to ask Dr. Erwan and maybe Dr. Weber and Dr. Edir Francis, what they do. They are specialists, that's the difference. That becomes a bit different. What do GPs do when they have breast cancer? What do our general practitioners do? If you guys can throw a light in this, Dr. Erwan, do you have anything to say? If not, Dr. Weber.
Yeah. Thank you for that question. Yes, in Bafia, we work with a good number of GPs. It is in their habit that once they see a kind of lesion which is suspicious of a breast tumor or a nodule of any type, they want me to see. And naturally, when we see, the tendency will be to kind of see how to do the biopsy, to get a mammogram and all of that, and send for biopsies and things like that. So I think that is the general image. But now, in Cameroon, we should distinguish between those who work in towns and those who work in the bushes. Because in the rural area, you will find many GPs who will get engaged in doing almost all of those things. I say so because I worked quite a long time under that type of context whereby you are the alpha and the omega. Like I said yesterday, one of our greatest problems is not only the cultural factors, but the economic factor, whereby you find clients that are not able to move to town to specialized centers and things like that. So you have the GPs, some GPs certainly in remote areas who will want to gamble with some of those things. And hopefully, I think that the knowledge that we are sharing and all these updates that we are making should be able to improve. You said something very important, that cancer management is not an emergency. I took note of that, because sometimes the tendency has been to say, look, let us rush so fast because it is going to spread and things like that. But the important thing is gather the knowledge, every information you need before you start the treatment. And I don't know, there are some treatment regimens. Are there some treatment regimens that create resistance to others? I have always had this question in mind, and each time I took the floor, I thought I would ask it, and it keeps on skipping my mind. Thank you. That's a little I can contribute while listening to the others.
Yeah, thank you. And I would answer your question, but I'm going to pass the floor over to Erwan. Are there cancer treatments that create resistance to others? The cancer cell is one of the most intelligent cells in the body. its job is to bypass any form of cancer treatment that is thrown on it. We have multiple types of ways we can attack cancer. We can do chemotherapy, and cancer cells do develop resistance in multiple ways against multiple chemotherapies. They develop resistance to bypass destruction of proteins. They develop resistance to pump the drugs out of the cell. I'm just doing in simple ways. They develop resistance to protect the cells against the chemotherapy itself. They develop resistance to even reduce the threshold for cancer cells to be killed. And in immunotherapy we do use the immune system to kill cancer. So we actually, cancer cells bypass that already. That's why immunotherapy works. So there is something in our body called, there are several immune pathways. There's the PD-L1, the programmed dead ligand. Cancer cells put it on top of them to say, do not kill me. When you have CD4 cells surveying around, they survey around natural killer cells. They are able to kill every cell in the body which is foreign. Now, cancer cells develop something and they say, do not kill me. The why we do use immunotherapy now is that we block the CD4, we block the PD-L1, we block the tumor cell ligand, we block the CTLA4, we block LAC. There are many other ways. And now these cancer cells become exposed. Immunotherapy is simply your immune system destroying the cancer cells, giving your immune system back hope to kill cancer cells. Now, for targetable therapy, cancer cells have certain targets that are different from normal cells. If we are able to identify these targets, an example is EGFR, which is EGFR1, MET mutation, RAS fusion, ROS. There are multiple of them, BRAF. We have drugs that we can target to just specifically, it's just like, rather than doing machine gun therapy, we do what you call precision medicine, where you have a sniper that is able to take down somebody from afar. And once we do that, we're able to identify these mutations on cancer cells and kill them. And that is what we call precision medicine. Cancer cells develop resistance to that too. They turn to stop producing EGFR and start producing something else. So what we do in the US, we actually, once patients have, like if I have a lung cancer patient, I have to do a next generation sequencing. They may have an EGFR mutation, exon 20, and I give them osimertinib. After 2 years of osimertinib, they progress. And I do a drug-resistant panel, and I realize that they are not resistant to alertinib, and I give them alertinib. It's just like how you do for infectious disease now. We are able to screen them over and over. There are some other kind of treatment called hormonal treatments where we are able to stop hormones, stop cancer cells from growing. They also develop resistance to that. There are other treatments like CAR T cell treatments where we are able to identify things like BCMA and other things that are specific just to that cancer in multiple myeloma, and we can take your cells and train them how to kill those cancers. So we do that in multiple myeloma. We're able to give you CAR Ts, bispecifics, and multiple other things. Oncology is amazing. The body is so amazing in the immune system. That is why I say infectious disease is light years away from learning from oncology, because this is the pathway where infectious disease has to go. But they have not done many research. They are still dealing with antibiotics, where they would have to have been dealing with enhancing the immune system to kill viruses and bacteria. So most fields are still to learn from what we do in oncology. I would want to tell you, it's just that this is not a field. We do miracles in oncology, trust me. There are cancers where people would never have thought we could cure people. Now we are curing them and giving them survivors that are unbelievable in the fourth line, fifth line treatment. Those are not things I'm here to talk about, because those are technologies that will take years and maybe so many years to reach us. But I have cancer patients, multiple myeloma, diffuse large B-cell lymphomas who are getting fourth-line treatments and are getting cured with CAR T cells, with bispecifics, with what we call BiTEs, with what we call several types of targetable treatments. So we do use a lot of things to cure, and all those things, as much as you are using them, cancer cells develop resistance. The question is, we need to be ahead of the resistance, but most of the time the cancer cells are ahead of us. And that is where the problem comes. And that's why we need to study the physiology, the anatomy, and the different pathological pathways they use in order to create resistance. So we are moving away from chemotherapy, which is just killing cells that are dividing fast. That's just the goal of chemotherapy. You are not precise in any way, and we're moving towards precision medicine, immunotherapy, use of targetable therapies that are able to give less. I have cancer drugs that cure you and have less side effects than your normal metformin that you give patients. Trust me. That's why we always say to our GPs and our internists, oncology is just so far away from internal medicine that do not put a patient on hospice anymore without calling an oncologist. 2 cancer patients who are in the ICU are not the same. A patient who has pancreatic cancer who is in the ICU and dying, or maybe even walking, will die faster than a patient who has lung cancer, non-small cell lung cancer with an EGFR mutation with multiple lesions in the brain. There is a pill I can give that patient, and if he responds to it, in less than 2 months, all those lesions in the brain will go away. He'll be able to walk and come to the office and do his job. And he may do that for additional 4 to 5 years. So be careful, because you cannot make that decision if you don't have that knowledge. So before you place anyone on hospice, we are telling all specialists now, before you do that, get an oncologist to be involved so that they can see what the prognosis is. The prognosis doesn't just depend on the functional status, it depends on the type of cancer and what we have available. So this is very important. Now I will talk still to try to answer Dr. Charles' question. I would call on Erwan to see if he has any input about what's happening in Cameroon. Is Dr. Erwan there? If not, is there anyone else who wants to share their experience about what GPs do in Cameroon? I was once a GP in Cameroon. So.
Hello, are you getting me?
Yes, we're getting you, Erwan.
Bye-bye. Okay, sorry, I'm driving and I was dropping some people. Okay, so what do GPs do in Cameroon?
With breast cancer.
From the little experience, I've had from them, I think it's all about the training that they had. There are some that are, let's say, good. They will try and do a sort of triple assessment. But most of the time, sometimes they don't know exactly what are the steps. That one, I think training should help them. Others are so afraid of it. So when they see it, they just push it towards the oncologist. But the thing that sometimes I'm a little bit, you see, Cameroon is a special place. There are some people, they are asking for imaging other lab tests because they have something that they kick back. You see? So sometimes they're asking things that are not necessary. Or something that maybe they will have issues after all with the oncologist. That's another problem. Sometimes you see a GP who has done the job, maybe he sees something, but he asks for a young woman, he asks for ultrasound, then maybe mammography. And then what happens is that when he does that, when he sends the patient to the oncologist asks why he asked all those lab tests. He should have sent the patient straightforward. Meanwhile, the guy didn't do anything bad. That's something very important. Next thing, most of them, they don't really know how to maybe perform a core biopsy. Yes, they can be trained for that because a core biopsy, especially when you have a mass like a T3 mass, of course, a core biopsy should not be a very big problem for a GP who is been with, maybe he's been trained, or he's working with a unit where maybe there's a surgeon or a gynae or a radiologist who is doing it. So that's my experience concerning the GPs in Cameroon. Yeah.
Okay, so thank you. At least we got some, Dr. Charles. You can get a big that there's an array of practices that are not standardized. I did train in Cameroon, and I worked in the regional hospital in Bamenda, and I also worked as director of a hospital back home. So I actually have experience in Cameroon, and I did residency in Cameroon. So I can tell you what I did and what we did was that we sent a lot of those patients to the gynecologist based on the kind of training we had. We send a lot of them to the gynecologist. In hindsight, I would have preferred to send them to the surgeons, the breast surgeons, but gynecologists are doing a wonderful job when it comes to that. They just need to get themselves up to date. Those who are up to date are doing a great job. Why do I insist? And I'm still going to say this very simply, evidence-based. All breast cancer patients should get, if you have 100,000 to spare, let them get their hormonal status. It changes everything. Everything in terms of treatment. You cannot treat them blindly. It tells you about the prognosis. It tells you about the diagnosis. It tells you about everything. Tissue is very important. Getting the right tissue and being able to biopsy the right tissue is very important, and using the right equipment. As I said, everyone is going to tell you we're still talking about core biopsy, but there are multiple biopsies I've seen from Cameroon which were still fine needle biopsies. You can actually do a fine needle in the axillary, but please, we need core needle biopsies. And it's also important that some of the equipments that they can use are very cheap and easy to access in Cameroon, because we are buying ultrasounds and all of that. So we should be able to have access to that. You cannot diagnose someone with cancer without having a biopsy. But just for a very important thing is that in Cameroon, I have seen multiple missed biopsies also because they were not trained. And a lot of them are not done under ultrasound, especially those who are done by GPs. So training is important, doing local training, trying to get, if a GP wants to do biopsies, they should be able to be trained on it. The problem with excision biopsy is that you're going to do surgery twice for a woman. And most of the time, the margins are going to be positive and you would have to plan. And most of the time, you will end up taking more tissue out for that woman's breast if you're planning to do breast conservation. It's something that is advised against. In the world where I study, it's advised against doing excision biopsy for the breast. You should do a core biopsy. It's easy, ultrasound guided. If you are not able, send them. That's why we have to train our radiologists to be able to help us with these biopsies, because they are more precise in doing them. And in calcified lesions, we need stereotactic biopsies because you don't have any mass. And that is how most of our DCIS actually are. That's why we don't even diagnose. The reason why you should not do a fine needle, you cannot differentiate DCIS, LCIS from cancer, because you don't have the membrane and you're not able to do that. So this, and you cannot also do histoimmunochemistry staining when you have cytology, when you don't have histology. So these are some of the things that we need to tell them, because I realized at a certain point, I always put myself back to when I was a GP in Cameroon. Did I know these things? Did anyone teach me when I was in medical school? And the answer was no. So I think a lot of those GPs don't know it too, because I was in their shoe and I practiced. There is improvement in knowledge availability, but there is lack of knowledge. It's not because, it's just because their mentors did not lay emphasis on teaching them those things. And that's our goal. I think our goal is to make sure that they know those things. Once you train people, their practice changes. That I can assure you. Every GP I've spoken to from Cameroon who has called me with a breast cancer case has changed their practice. And that is how I call change. Everyone who has spoken to me, I can assure you, has changed their practice. They have even advocated for their patients more than some of the specialists that were seeing these patients. I had a young guy who called me from Garwa Dublai or somewhere in the north, had this breast cancer patient, and there was no, and he actually succeeded in getting the estrogen, the progesterone level, getting the scans. Patient had already metastatic disease. They were planning to do surgery in L'Hôpital General somewhere there, and actually started this patient on anastrozole based on really the real guidelines. And the surgeon saw later on with all the scans and metastasis, and he questioned the surgeon. So educating the young generation in anything is important. It goes to with prostate, because we are going to talk about that one day. The act of doing prostatectomies to patients who have prostate cancers already. So this is something that I feel, to me, is a passion, and it's also a calling that we need to be able to get people to know. And I think that by educating the younger generation, the older generation will fix their practice and will learn, forcefully learn, because their students will question them. So I think that's just part of the take. Nobody else wanted to opt about what they do. Any other questions before we close the session? And Dr. Maxwell Fomuta, do you have anything to say?
Well, just to thank you for this brilliant, depth of knowledge that you are willing to share every week. For those who are back home, we really thank you for all the efforts you make with the limited resources. We are really glad that more people are open-minded to learning. We also hope that some of our professors can be humble enough to learn. We are not here to be defensive. We are here to improve and grow. And that's really the magic behind us progressing as a nation. So thank you again once more. We look forward to so many such presentations from different specialties. I spoke with Michelle, we spoke yesterday, as a matter of fact, and I was telling her about some of the issues I saw in Cameroon, which I would hope she would chip in as an infectious disease expert. These are much, like, we really, really need this knowledge. We need to share. For me, it's like when you come abroad, you should be able to go back home and give your people what you've learned abroad. You do not have to, sit on it and feel comfortable. You should challenge yourself and give back home. And this is part of it. Thank you, Munoh, for inspiring us. Thank everybody, Dr. Weber, for being such a wonderful grand frère, humble, open to learning. Tambe, everyone, I'm really, really inspired by the work you guys do. I've never met you guys before, but I feel like I've known you for the last 20 years, just because of your contributions and how you see the world. So thank you all for always being here. And we hope this town hall lasts forever. Thank you.
Okay, thank you. And any last words? Brunhilde is working. Any last words from anyone?
Yeah, Dr. Munoh, thank you. I want to, not maybe the last word, I want just maybe that we get something back home. I think the role the diaspora has to play has really been emphasized. And what you are doing is exactly what the Cameroon government is expecting. And I think that the ministry opened up to see how the diaspora can effectively, collaborate. And I would really wish that with the world of experience that you have, something concrete should be created to link us permanently. Yes, we have training sessions, which is already the beginning of it. And yesterday I was like thinking that maybe a WhatsApp group can, again, keep us very, very animated and permanently. But the diaspora, local doctors, if I may call it so, national doctors kind of partnership is very important. And personally, I'm thinking of how that should happen. And I wish that all of us, I noticed that when we attend these town halls, you have many of you who are abroad who are participating. You are exposed. You are more exposed than us. But sometimes I feel that you are more, again, than us here who are really thirsty for the knowledge. And really, let us think of how we will, harness these efforts and make them permanent and sustainable. Thank you.
Yeah, thank you very much, Dr. Weber. And it's something we're going to think about. And for me as an individual, I strongly respect those who are back home. A lot of them are my friends. They were my classmates. I have a lot of respect for their intelligence and their knowledge. And I truly feel that all we need to do, and I learn a lot from them. It's a two-way street. It's not even a one-way. I always tell those who are abroad who trained in the US, if you go back home, you will not be able to practice. And it's true. Because the standards, the things that are there are different. And I understand that very well. but it's important that we also get ourselves into a system where we can improve, where we can have continuous knowledge, where we can have updated knowledge, and we can give our students the best knowledge that we have. So I'm always of the opinion, even by creating the town hall, when we did create a town hall, to me, it has always been a forum of exchange. There are days we come in, we're more critical than other days, but to me, it's a forum of exchange and we learn from each other. And there are many things that you can, so I don't think it's always going to be that the diaspora has to come tell the host home what to do. No, it's for us to have meetings and decide what the best way forward should be like, and how we can collaborate with each other, how we can listen to each other and understand why we're doing what we are doing, and how we can prioritize. Because us in the diaspora, we still have our mothers out there. My mother was sick some few years ago. Those in the regional hospital, she was a general supervisor there. They took care of her. I cannot leave Cameroon and go take care of her there. They took excellent care of her, and the best way for them to help take care of her is for them to be up to date with what is going on, and they took care of her. We have our grandmothers there, we have our sisters there, we have our cousins, our nieces. So if you think you can shade yourself, and I actually hold those who are staying back home with a lot of pride, because despite all the mistreatment coming from the government and poor pay and poor living conditions, they are still there. And those conditions can actually lead you to do things that are unethical. I've been in Cameroon just for the sake of money, just for the sake of trying to keep your family together. So there is a very thin line between ethics at times and survivor. So there are certain things that people do in Cameroon. The same people moved over to the US and they did not do those kind of things. They knew better. So this is a complex relationship that we need to make it go on. We need to make sure that it continues, and the diaspora also needs to come in a bit humble and ready to learn. And ready to learn and collaborate. And you should not criticize without giving solutions. I know I love criticism, but I always like to give solutions. But you should not criticize without giving solutions, because that's useless. Anyone can criticize, but not everyone can provide solutions. We should be able to be solution-oriented and collaborate, really. So thank you very much. I would work on it, Dr. Weber. I have your number, but it's a difficult, it's always going to be difficult to get that kind of engagement, but I think it's the way forward. Yeah, okay, so any feedback?
Munoh.
Yes.
Yes, yeah. Well, excellent and a brilliant presentation as usual. I'm always here to learn, and I always learn a lot from you. Question, have you thought of having like a WhatsApp? I know there's so many WhatsApp groups, and people get tired of it. Like a town hall WhatsApp group where, I mean, we can not only having these presentations, but if people have like cases where they want to share, where you have probably different experts there, and maybe share how to address some of complex cases or difficult cases. I mean, that would probably be something to think about, because I'm sure those who actually are in the town hall and who attend them are generally people interested and willing to learn. So I think it would be a good forum if you're able to do that.
Yeah. Excellent suggestions. Excellent suggestion. Excellent. That's all I can say. Maybe next year we'll move as one of our objectives next year. It's an excellent suggestion. Only thing is multiple WhatsApp fatigue syndrome groups, but it's an excellent suggestion.
I mean, I know we have some other physician groups, but it should be a political. We should avoid. It should be specifically, I mean, for cases or something like that. Knowledge, not. Yes, yes, not anything in politics or we have a lot of those, or not anything entertainment. We have a lot of those issues. I mean, just like the town hall, I think the people who are attending this town hall generally are serious. So it should be in the same line. And then the other thing is, do you think you can also maybe these your lectures that you're giving now, are you going to also upload them on the YouTube channel? Because you didn't say anything.
Yes.
Okay, just so that people know too.
I'll update them on the YouTube channel, and for those who participated, who are interested, I'll send them a copy. I don't want a habit. I get, each time we're done, I get a habit of receiving emails from millions of people wanting the lecture who do not want to participate in the lecture. That's, to me, that's an academic dishonesty. Even though it's going to help, but they should listen to the lectures and be able to be willing to sacrifice time to learn and ask questions.
Yeah, I do believe, I mean, to tell you the truth, I believe that with time, you have a lot of, even students, this, if we just keep doing this, it's just a matter of time, because this is something so valuable. Even, you know, you may think we don't have a lot of students now, but I can almost guarantee you with the amount of knowledge and of updated information, this is, so it's going to be, I mean, we'll have traction with this this line of seminars and topics, and who knows, even it may even become a CME thing.
Yeah, I was planning on actually registering this as a CME, just that it came a bit 1 week. I would have done this. It's easy for me to get CME accreditations that I wanted students to get CMEs out of this. So the future lectures are going to be CME directed lectures. So this is really something I feel like, but it's important that people know too that some people just send me emails, oh, can you send my slides? If you were there in the lecture, I'm going to send you the slides. If you were not there in the lecture, it's just an academic dishonesty. Putting all of this together takes me weeks to do. Though I want everyone to learn and train, but you need to be willing to do that rather than just use the slides and maybe do your own lecture somewhere. That's not how it works.
Thank you very much for all you do.
Yeah, thank you. So we are almost at the time, and just want to, Dr. Innocent, DB, do you have any questions?
Dr. Munoh, brother. Yeah, I'm just glad that you took upon with a couple of others this initiative to try to drive a positive social change in our community, in our country, and why not Africa? I'm glad with the efforts that you have put in. I'm glad, you know, that this might one day lead to maybe a policy change as well. I'm with the CDC, Department of Pathology, C cells and infectious disease, and evidence-based medicine is what we rely on. We fought COVID because of data, you know. So I'm really glad the way you're taking this, and I think that, you know, by God's grace, one day, you know, we'll see changes, especially in our country. Thank you, you guys all. Thank you, Dr. Munoh. I appreciate this. I'm glad to be part of it. Thank you.
Okay. So thank you, everyone. Unless someone else has something to say, God bless you all. And next week, we are going back to our regular town hall. This was just a special session. We didn't want the week for breast cancer to go by. And we did not want ourselves to be just critics of what is happening to Cameroon. Rather, we want to contribute to making things better. And we're going to have these lectures available online. And the hope is we're having other specialists. If there is someone in Cameroon, you're doing something special that you want to tell us in the town hall, just send us an email. We'll give you the audience. The town hall is meant not just for the diasporans, it's mostly for those who are back home to tell us what is happening and how the diaspora can help. And I think I need to reach out to some few people who had contacted me, because the town hall is really open to getting new speakers who want to talk about change. So I have to reach out to Professor Joshua Tambe. I've been very busy. I think I'll call him immediately after this. So if there are any changes, please just let us know, and we are going to get people over and provide a medium for them to express themselves. So if you know anyone, just let us know and give them the right media. So thank you all. God bless you, and see you next Saturday.
Thank you.
Official town hall is every 2 weeks. So this was an extraordinary session. So yeah.